Good morning, Trina, and good morning to everyone. I would like to welcome to today's Health Scrutiny Committee, including everyone present here in the Council Chamber and those who are listening online. Before we begin, for those of us in the Council Chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also like to welcome Councillor Colin Matthews, who is attending via Teams as the Executive Support Councillor. Oh, morning Colin, didn't see you come in there. Okay, well, welcome to the actual meeting this morning, who is the Executive Support Councillor for NHS Liaison, Community Engagement, Registration and Coroner's Services. Other participants will be introduced when we reach their item. I would also like to ask for all mobile phones to be switched off or to be placed on silent, please. This meeting is being streamed in the usual way, and so I would ask you all to please switch on your mics when you speak and switch them off promptly afterwards. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillor Reid and also Dr Brian Wookey, but we have substitute members today. For Councillor Reid, we have Councillor Whittington, and for Dr Wookey, we have Dr Maria Pryor. Thank you, Chairman.
Thank you, Trina, and welcome Councillor Whittington and Maria. Nice to see you again. Thank you. We'll now move into agenda item 2, declarations of members' interests. Do members have any interest to declare, please? No, thank you. In which case we'll move straight on to agenda item 3, the minutes from the 13th of October. I would like to confirm the minutes, which are found on pages 3 to 15 of the agenda pack, as a correct record. As the committee have had an opportunity to read these in advance of the meeting, I plan on taking these on block. Is there a proposer, please? Thank you, Councillor Wootton. Do I have a seconder, please? Thank you, Councillor Allen. In which case, all those in favour, please show. Thank you, that's carried. Any abstentions? And any against? No, thank you. In which case, I'll move straight on to agenda item 4, the Chairman's announcements. My Chairman's announcements have been circulated with the agenda on page 17 to 28, and my supplementary announcements were emailed on the 9th of November. Are there any questions on these at all, please? Councillor Wootton.
Yes, thank you very much indeed, Mr Chairman. Can I refer to page 3? What's of concern to me is that in South Kesteven, and particularly in Grantham area, people are of the opinion that the coronavirus is over. People are not wearing their masks, they seem to be oblivious to the risk. Yet looking at this data on here, we have one of the highest in the area. Can you give me any explanation as to why that is? Thank you.
Yes, certainly. Thank you, Councillor Wootton. I think there is a high prevalence all across the county and actually all across the country at the moment of time. Of course, I think the relaxation of restrictions will have caused this, and of course we're getting into the winter period where things like colds, flus and COVID really prosper. So I think unless I suppose they bring back some form of restrictions, we're liable to see this increasing, because unfortunately people, unless they're instructed to do so, won't necessarily stick to wearing masks and so on. So I think it's just one of the unfortunate events of removing all the restrictions.
Thank you, Chairman.
Councillor Woodliff.
Thank you, Chairman. I'm just turning to page 18 and the plans for the expansion of the A&E department of Pilgrim Hospital. There's quite a lot of interesting comments here, but there's nothing about more staff or more doctors or more trainees, more nursing staff. It's not about rooms. My concern about anything like this is that, all right, you can double the size of your building, but does that mean you're going to double the size of your staff? And the other thing I'd like to ask a question about, it does refer back to the minutes, is on page 10. It's a pity that this particular information on page 10 couldn't be well publicised. It says that it reported the number of GPs has been falling consistently. In March 2016, there were 515 GPs for every million patients, and now it was 463 for every million patients. I've just kind of adjusted the figures because I don't like 0.5 of a GP. I don't know what it means really, unless you cut it in half. So there's clearly an issue here with the staff and the falling numbers. Now, I know the government has promised or did promise extra 5,000 GPs and so on. Easy to make promises, not quite so easy to deliver. That's a very serious figure, I think, and it really needs to be publicised so people actually do know, that there's a very serious shortage for GPs. In fact, there's a loss of another 600, isn't it, or so. But my comment goes back to number 4 on page 18, all right, which it links in with it, doesn't it? Links in, double in size, more state-of-the-art innovations, bigger resuscitation area for the sickest, more cubicles, separate area for emergency care, more training rooms for staff, a much better environment for patient staff. That's fine if there's more staff, more doctors, more trainee doctors, more nursing staff. That's the question. Is that so, or is it the same numbers of staff and bigger buildings? I better leave it at that, Chairman.
Yeah, thank you, Councillor Woodliff. Of course, recruitment and retention is an issue throughout the country and Lincolnshire. And of course, expanding an A&E department is very welcome, but you're absolutely right. Without the staff being there, it could potentially lead to further problems. However, they do say from the NHS locally that any time that you improve an area, improve a hospital, it does help with that retention, and I would certainly hope that would be the case.
Thank you, Chairman, very much for your support.
Councillor Cleaver.
Thank you, Mr. Chairman. On point 3 on page 1 of your supplementary, you refer to the new Urgent Community Response Initiative. Could you tell me if that is actually county-wide, completely county-wide? And if so, do we know how the service is actually spread across the county in terms of the volumes of care that it's providing?
Simon, if I may bring you in.
Thank you. Thank you for the question. I'll have to get some more information on this. I'm sorry, I'll have to find out. My understanding is that it is a county-wide service, but I will double-check that. Thank you.
Thank you.
Thank you, Councillor Cleaver, and if that could be fed out to the rest of the committee, I think that'd be useful. Thank you, Simon. Okay, Councillor Whittington.
Yes, thank you much, Mr. Chairman. I'm referring to page 6 of the minutes. It's the second to last paragraph, and it's the last sentence. It relates to Grantham Hospital A&E and the UTC. And the line is, the committee was advised that during the temporary period, the UTC had been well used. Officers agreed to make the data available to members of the committee. I know I was a substitute member last meeting for SK, and today I'm a substitute member for LCC. And I'm just wondering if that data has actually been made available. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. Not as of yet, we have chased it, so we're just waiting for a response. Okay, I don't think I've got any further speakers, in which case, do I have a proposer that we note my announcements, please? Councillor Linda Woodson, thank you. Do I have a seconder? Councillor Allen, thank you. All those in favour, please show. Thank you, that's supported. In which case, we'll move on to agenda item 5, just after I've gone over the questions and meeting conduct. So before we move into the substantive part of the meeting, I would like to ask that you keep your questions and contributions succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. In which case we'll now move on to agenda item 5, the Lincolnshire Acute Services Review, starting with the stroke services. This can be found on page 29 to 59 of the agenda pack, and I would like to welcome our presenters via Teams, which is Dr. Abdul El-Marimi, Consultant in Stroke Medicine for United Lincolnshire Hospitals Trust, and Charlie Blythe, Director of Communications and Engagement for the Lincolnshire CCG. If I can hand over to you for about 10 to 15 minutes of the presentation, and then we'll move into questions afterwards. Thank you.
Good morning.
Morning.
Can you hear me?
We can hear you perfectly, thank you.
Good morning, and thanks for inviting me. My name is Abdul Marimi. I'm one of the stroke consultants and currently the clinical lead for stroke services in Lincolnshire. I trained in stroke medicine in Guy's and St Thomas's and King's College, and I did a lot of stroke work over the last 12 or 15 years. So stroke is a passion. I would like to update you sort of just by starting with a very, very brief introduction about stroke itself and then about the service and why we're doing what we're doing or what we want to do. Stroke is an illness that affects not just the physical body of the patient, whereas a clot blocks an artery that goes to the brain and stops the brain from functioning temporarily if there's an intervention, and possibly permanently. Stroke leads to a lot of disability. It is the #1 cause for disability in the developed world. There's about 110,000 strokes a year that we look after in the NHS, and that's a large number given the risk factors. So in terms of dealing with stroke, like I said at the beginning, it's not just the illness of the body, but the fact that stroke is about loss. It's about losing independence, losing bodily functions, but also losing livelihood, income, possessions, family, home, when someone can't do what they are used to do or want to do. So it's a really, really serious illness. And this leads me to what we can do for stroke. I mean, in terms of treating stroke, there are 3 interventions that have been proven time and time again to help the most with stroke. And these are, in terms of chronological order, admission to a stroke unit. This has been shown since the 90s, that being admitted to a dedicated specialist stroke unit reduces mortality, reduces disability, more of a chance of going back to closer to normal life, less incidence of complications, and less long-term disability and effect in terms of family life. The second intervention is the introduction of a clot-busting treatment, which again has been used since the late 90s in the States and in the early noughties here in the UK. So this is an intervention for only one type of stroke, in which case there is a clot. Strokes that are caused by a clot are about 80% of the total number of strokes, and this treatment applies to between 10 and 15% of those patients. So when you kind of drill down the number, it's not exactly the treatment that we will give to anybody. There's a select few, but for those who receive this treatment, there's less likely chance of disability. There's a small increase in complications because it thins the blood so much to dissolve that clot. So people tend to have bleeds in those patients, but that is less than 5% of the total number of patients. The third intervention is a mechanical treatment. So it's called mechanical thrombectomy, in which case that in the same way that they do a cardiac stent, they access inside the brain vessels, and the clot is sucked out of the artery in the brain where it's blocked. This is a brilliant treatment. It's only started a few years ago. We offer this treatment in QMC in Nottingham as far as the East Midlands is concerned. So in terms of these treatments, they're kind of build on each other. So each time we get something new, we move with the time. So the best results for a stroke patient are dependent on being admitted to a dedicated stroke unit, getting the clot busting treatment, and if they qualify for the other treatment, then to go and have it as well. So this is the scenario for the best sort of stroke care that you can get. Not everybody gets that. What's important is the fact that we're looking at the intervention that benefits 100% of the patients rather than 1% or 10%, which is the sort of the values for the other 2 interventions. So being looked after by people who look after stroke day in, day out, know how to deal with the complications, how to work with the patient. Just to give you a very, very quick example, stroke is not always when someone can't move their right or left side. Sometimes they can't express themselves in words. Sometimes they can't see what's on their right side or their left side. So if people are unaware of their left side, if you leave their drink or their food on their left side, they won't see it. It doesn't exist to them because the brain doesn't register because of their stroke. So you need people who are fully aware of how to deal with these sort of complications in terms of if someone can't eat a certain consistency of food, then you have to adjust it for them. So this is the importance of having specialist staff rather than just generic nursing or a non-specialist doctor or therapist. Moving on to the situation in Lincolnshire, I have been here for 8 years last month, and we had, or we still have, 2 stroke units, one based in Boston and one based in Lincoln. We're providing services from both sides until when COVID started, and we ended up in a scenario where we lost half of our consultant workforce overnight because of isolation, and because we had temporary doctors who decided not to work for fear of COVID and its complications. So we had to move to a sort of a hybrid working pattern where the front door treatment has moved to Lincoln County Hospital because of the fact that we have more staff and we have another tier of specialist nurses called advanced care practitioners in Lincoln, but we don't have that resource available to us in Boston. And that is how we're working. But the rest of the treatment in terms of rehabilitation and outpatient activity continues on both sides. I have been involved in the previous discussions for STP and LHAC, as well as healthy conversations in terms of the future shape of the stroke service in Lincolnshire. And we've been through discussions, conversations, consultations, public events. And what we're presenting as our preferred option out of all of this is a centre of excellence where we pool our resources specifically for staff in one place that will become more attractive for stroke doctors and nurses and therapists and assistants to work from. So from a staffing point of view, we're starting with the most acute shortage, which is the shortage of stroke consultants. There was a report by the British Association of Stroke Physicians published in 2019 about the dire state of staffing, and I can hear one of your speakers earlier on talking about GPs. You know, I can give you worse things about stroke physicians, but it's not a competition, I'm afraid. So we have at the moment 676 stroke posts, for stroke consultant posts in England and Wales. 40% of these posts are vacant and they're filled by temporary doctors. That is a very, very significant number. In terms of the requirement, as assessed by stroke numbers and stroke units and beds, we require another 226 stroke consultant posts on top of the number that we already have. If you look on NHS Jobs website, where we advertise these posts, the last time I checked last week, there were 30 advertisements for stroke consultant posts, and there's more that are kind of given up on advertising, and they're happy to use temporary, very, very expensive locum doctors. So there aren't a lot of doctors around looking for these jobs, but there are plenty of them. Just to give you a sort of a real life example, I represent the Royal College of Physicians on interview panels, and a few months ago there was a post in a big teaching unit, extremely desirable, and I was invited to represent the Royal College. And the day before the interview, I was contacted to be told they've cancelled the interview because nobody applied. That was unheard of when I was a trainee. There's no way that you can have a unit as big in a big teaching university hospital that nobody applied, let alone people applied and you know, kind of were not good enough or even got to the interview stage. So in real life, it is very, very difficult to get these people, and we're struggling. We were struggling on both sides. Even now, with one side, we're struggling to get the quality of people that we want to look after our patients, and we're kind of working on a hybrid between us substantive people, and there aren't too many of us. There's me at the moment. And temporary doctors and trainees and people that we're training ourselves to become stroke specialists. So that's in terms of doctors. There is this element of which place is more attractive than the other. I'll get to that point next. But that is just one element in terms of the acute shortage of staff. for consultants. We will need 7 consultants to be able to run the unit as it is. We don't have that at the moment, and that's just to run one place. The recommendation from the British Association of Stroke Physicians is that each unit needs to have 6 people to be able to run an efficient service. And obviously, if you have, like we had before we moved with COVID, 3 people on each side, it is extremely unattractive for a person to come to be the 4th person if compared to you advertising for a job and you're saying you're going to be the 6th person of 5 people or the 7th person to 6 people. It means you can have more time with your family and you can settle and do a good job rather than just being either on call or was on call or going to be on call the next day for 24 or 48 hours non-stop. So the attractiveness of the job isn't there. There are people who are leaving stroke medicine to do other specialties, unfortunately. So we don't really have the attractiveness of the job itself. That applies to therapies and nursing. When we did the healthy conversations, our figures for nursing weren't any better in terms of how many people do we have. So for example, the vacancy rate for Pilgrim Hospital for nursing was 57%. So that means that more than half of the nursing staff that we have are temporary and they're not permanent, which means they can leave on an hour's notice or not turn up at all. The figures for Lincoln at the same period of time, I think, was about 30%. So we have the staffing issue. To be able to look after patients, we need to have these people looking after our patients as much as possible. When we moved with COVID, the shape of the service hasn't changed very much because we're still transferring our patients after the first 3 days, sometimes 7 days, back to Pilgrim Hospital to receive their therapy. But my understanding is that I'm here today talking about the ASR, not what we're doing about COVID. However, I think it's a very good example that this is kind of a test drive for what we're trying to do. And just by way of an update, I looked at the figures and the data from the first 6 months of the change because of COVID, because I was very concerned about the fact that some of our patients might miss the clot busting treatment because of delay in transfer or not get transferred back in time. Is there any increase in mortality for these patients because of the delay in their journey? And what I have found, that there are delays in terms of receiving the clot busting treatment, but they were not caused by the transfer to hospital. The ones that I have seen were about 11 patients. They presented late, and there was one patient who did not call an ambulance, but just decided to be driven to hospital. We will always get these, and we can't really change the fact that some people do not have enough faith in the ambulance to be at home on time. But part of our plan is to maximize public engagement and education. So we couldn't find any evidence that people missed the clot busting treatment because of delay in the journey itself. The journey was not longer than an hour for the patients that I have reviewed, and I reviewed 6 months worth of data, which is available. What I have noticed is for the third more advanced treatment, which is the mechanical thrombectomy that happens in QMC in Nottingham, is that prior to May 2020, when we moved to a single site, Lincoln has transferred 9 patients to Nottingham to receive this treatment, as compared to 1 patient who was referred from Boston. Since May, we have sent 9 patients from the Lincoln area and 8 patients from the Boston area. So that means that there is an improvement in terms of the care that these patients might get, because what happens with the thrombectomy, you have up to 24 hours to receive this treatment. So even if we end up with a patient who missed the clot busting treatment because they arrived more than 4.5 hours, we can get them to Nottingham to receive the extra treatment that takes the clot mechanically out of their body rather than by using an injection. In terms of what we want to do, we want to bring all of our teams in one place. We want to increase the bed numbers to be able to accommodate the number of patients. We work at the moment on 28 beds in Lincoln and 24 beds in Boston. The reality is that given that the catchment population and the incidence of stroke, we expect and we have something like 700, 760 strokes per year from the Lincoln area, about 400 to 480 strokes in the Boston catchment area. And that's, again, is a bit of an anomaly because 250,000 catchment translate elsewhere to about 350 strokes. The annual incidence of stroke is something around 1.2 to 1.5 per thousand per year. So we know we have more strokes than we anticipate, but it's not the critical mass which is recommended by the Department of Health or NHS England, which is 600 strokes to keep a unit busy. What we see also out of these 24 beds in Pilgrim Hospital, they're not used by stroke in the same way that the 28 beds in terms of stroke occupancy. It is higher in Lincoln in the sense that there are more stroke patients coming in on a daily basis as compared to the beds that are required in Boston. When we look at the travel time and the sort of displacement, I think you've got the figures in the graphs in terms of the preferred option, but we also worked on the non-preferred option. We worked on status quo and we worked as option 4, which I think is not one of the options included, but it's what if we base the unit in Boston rather than in Lincoln? And what we have found, I think it's in the text in the document that you have. What we found is that the displacement is much, much higher in terms of the total number of Lincolnshire patients being treated outside Lincolnshire, which also has an impact in terms of travel as well. In terms of attractiveness to staff to come and work, we have found, since I joined here, we've been advertising for jobs on both sides, to be honest, for both Lincoln and Boston. We have not had an applicant for Boston in the 8 years that I've been here. We had about 3 or 4 applicants. We appointed 2 of them in Lincoln recently. And that's on the background that, we are moving the service to a shape that is attractive to people, where you're going to have 5 or 6 colleagues and you're going to have a better quality of life and a better work-life balance. That's, remain to be seen whether they stay or they go, given what we have, because these people are like gold dust and people are enticing them with all sorts of things. And we can't guarantee that anybody will stay more than 3 months, unfortunately. So we looked at what if we base the unit in Boston, and we found that the attractiveness in terms of people relocating is one thing, but also the displacement. The other thing, obviously, we have, like I said, we've developed a group of expert stroke nurses who at the moment are the backbone of the service. They're running this model. The model wasn't adopted in Pilgrim Hospital, unfortunately, at the time, so it doesn't exist. And even then, here in Lincoln, we don't have enough of them. We have just about enough people to run a 24/7 service, and we're working on increasing the number substantively or substantially as soon as we build the service the way we want it. In terms of travel time, for places like the coastal areas or Spalding, for example, it is a problem. I'm in no illusion that this is something that we clinicians can fix, but as an organisation, what we're looking at, from my point of view, is if the patient comes to the right place first time round and sees the right people, their length of stay in hospital will be less. Their level of disability will be milder, and with an enhanced community service, people will be going home sooner to receive that therapy closer to home or at home rather than being in hospital. It's the choice between going to the right hospital or going to the nearest hospital, which may or may not be right. If you compare it to the cardiac centre or trauma major trauma, for example, we move people to where they need the treatment to be. And the evidence from the cardiac center in Lincoln is undisputable that bringing patients from all over the county to a single site where all the experts are improves lives, improves mortality, and there's more patient and family satisfaction. If you have to go to visit someone 3 times before they go home, and they go home, in my view, it's much better than going to visit them 15 times and they're still in hospital 3 weeks later. So that's kind of one of the mitigating factors, in my view, in terms of the quality of the clinical service. I think I'll stop here, unless there's anything that I have missed that you can ask me about.
That's lovely, thank you. I'll open it to questions then, please. Councillor Whittington first.
Yes, thank you, and thank you very much for a very interesting presentation. I've just got 2 questions, and the first is around sort of the problems you've been having in recruiting consultants and dependence upon locum staff, because I'm assuming that the locums have to have the same sorts of professional qualifications as the consultants. So are these locums, you know, when people are working locum hours in the service, are they our own consultants who are kind of doing extra work? Are they locums that are coming in from other hospitals in the area? Or are they what I would term professional locums? Because when I was an accountant in the health service, we identified an issue that a lot of people whose skills are in high demand tending to operate almost as professional locums, because obviously locum rates are a lot higher than the normal rates of pay. And quite a lot, there was definitely a cohort of individuals who just seemed as if they were quite happy to be professional locums. They could actually find they could have a high rate of pay and potentially then, obviously, as you said, not particularly commit to any one unit. They could come and go as they wanted to, and they actually did it really so they could almost manage their work-life balance. So is there any indication that that is an issue in terms of people preferring to take the locum route as opposed to applying for substantive posts? And my second question is around the time from the sort of the hour period that you mentioned, and I'm assuming that is the hour from when the call is first received by the ambulance service, the 999 call, to the patient being treated in hospital. And I'm assuming that, obviously, you know, we're aware that obviously in A&E departments there are waiting times of quite a number of hours, and also evidence that patients are also spending several hours in ambulances waiting to be actually waiting to leave the ambulance to go into A&E. So I'm assuming that stroke patients are kind of, because of the nature of it, are rushed through the system. So as soon as they arrive at Lincoln, they go straight from the ambulance out into the service, which kind of is supported by, because I attended the Grantham open consultation session a few weeks ago, and I did speak to, and there was a stroke nurse there from the Lincoln unit, and she said that when stroke patients are in the ambulance inbound to Lincoln, the stroke department are in constant contact with the ambulance service to monitor the patient en route, so that when they arrive at Lincoln, in effect, they've done a lot of the basic triage work in advance. So could you just confirm that is the case, and then when patients arrive at Lincoln, they don't sort of go through the normal A&E and ambulance waits and go straight in and receive their treatment? Thank you very much indeed. Thank you.
Thank you. I'll start with your second point because I think it's very interesting, and I've missed that part. Part of the remit of the stroke specialist nurses or the advanced care practitioners in Lincoln is to be available 24/7 to take the referrals from the ambulance team. Most of the time, the paramedics will ring from site when they're seeing the patient. So that's when we sort of start the clock, in other words. So when we get the referral, we have access to different databases, medications, old scans, clinic letters, discharge letters, sometimes clinical notes as well for these patients, and we kind of go through the assessment. What we have built in Lincoln is a relationship with the cardiac team. So we use their sort of area, the cardiac catheterization lab, the Lincolnshire Heart Centre, to bypass the very, very busy A&E, so that we don't really waste any time. We normally anticipate the times that I remember going, we sometimes see patients in the ambulance itself, en route to the heart centre, en route to the scan. That period of sort of arrival to scan is very important. And we have been, I mean, there's a national target of 50% of these scans to be done in an hour. We're hitting about 60% of these scans in an hour, as per our latest figures. So we're kind of, that is something that's been drilled. That's the difference in terms of, say, for example, getting people to Nottingham to have their thrombectomy treatment, is because the system is well oiled and has been running for a while. These things are being considered as the patient is on their way. So we don't have an hour in terms of cardiac golden hour or door to needle in an hour. We have 4.5 hours from onset, unfortunately. So when the patient developed their symptoms, we have 4.5 hours to give the clot busting treatment. I have to go back and say this treatment applies to less than 10% of the total number of patients, but it's still important. It has to be given on time. So the time frame has been improving continuously because of the way that we try to modify our practices in terms of how we do this and how we've been doing it for all of the patients in Lincolnshire over the last year and a half. On the second point of locums, you're absolutely 100% spot on. There has been a major shift, I think, in the last few years that some professionals don't think of medicine as a career or as a vocation or as a dedication to something, but unfortunately as a skill they can sell to the highest bidder. So I know of people who left their substantive jobs to become what we call a professional locum, or what we call them locumologists, and because the problem is, if I want to take time off, I have to organise with 3 or 4 or 5 people about being off at that time, which could be a school holiday, could be a wedding overseas, it could be anything, and we have to make sure that the service runs. These guys just say, I'm off tomorrow, or if they're nice, next week, and there's very little that we can do about it, because the shortage is so bad that you just you have to take what you're given. A lot of these people just sell their skills. We try to get the best ones, not always that we're successful. Patient safety is my priority and our organization's priority. So if we have any doubts about someone's safety, then we ask them to leave. But what's available on the market is not a lot, and it's not all of the same quality, I'm afraid.
Thank you, Councillor Whittington. I have Councillor Cleaver next, please.
Thank you, Mr. Chairman, and thank you for your presentation, Doctor. I have one question and one comment to make. In the public consultation document, it says that national best practice is that hyperacute stroke units should admit a minimum of 600 patients a year, and that Boston is only admitting 500 stroke patients a year, which does seem quite a lot, and is in fact almost 10 a week. So I find it surprising, and I'm sure anyone else reading this document who's a layperson would find it surprising, that when you're treating nearly 10 patients a week, there is a risk of the staff becoming de-skilled. So I would like to hear a better explanation of that, please. And I'd also like to make the comment that given that the south of the county is so dependent upon services at Peterborough and Kings Lynn, I don't think this review can be viewed in isolation without taking into account the plans of the neighbouring authorities for stroke services in those hospitals. Thank you.
Thanks. Yeah, I completely agree. 500 and 600 don't seem very much different, especially if you work on population growth. What we have noticed over the last 10 years from a sort of a very, very simple epidemiological point of view is that we're preventing more strokes. The number of strokes happening are not increasing in the same way as people age and have other risks for stroke. And part of that is sort of primary care doctors, GPs are working more on prevention for things like irregular heartbeat. There's more awareness and more treatment for this that is available, and that is preventing more strokes. But we've moved from a time in 2008, I was a stroke consultant elsewhere, and we were told that any unit that doesn't admit 350 strokes will have to shut because it's not, it's not seeing enough activity. That was 2008, 2009, and then we moved on, and then we've come to this view that it's 600. It is likely with advances in treatment and the fact that you can treat a stroke by taking the clot and using a catheter that goes through an artery even up to 24 hours, that this level of activity will change again to be able to deal with these patients. The other element of it is the expedited discharge will play a major role in terms of the numbers that you see. You could possibly see 500 strokes. One of the quarters of our audit, we have a national audit. Stroke is possibly one of the most scrutinized specialties in terms of medicine. We have a national audit that's been going on now for about 15, 20 years. The current version of it is called SNAP, Stroke Sentinel National Audit Program, and it looks at something like 90 odd parameters per patient per admission. And one of the things that we notice is the stroke severity element of it. You can have strokes that are so severe that the patient will possibly be in hospital forever, or pass away in hospital, or end up in a nursing home. And even for something as severe as that, the outcomes can be very stark. So you can have someone being in hospital for 3 months, waiting for a feeding tube and a nursing home placement, or they sadly pass away within 3 or 4 days, or those decisions be made by the specialist team that this stroke is so bad that we need to cut and move on to sort of a placement out of hospital. The reason I'm saying this is that you could see 500 strokes, but they do not need the same bed base and the different level of experience that you will need for 800-900 strokes that are completely different in terms of quality. The stroke severity measures within this seem to look that in certain periods of time on SNAP, we had less severe strokes, much more of these coming to Pilgrim as compared to those coming to Lincoln. At the moment, it's very difficult to compare the last year and a half because we don't have direct admissions to Pilgrim. In terms of future planning, the number of strokes will possibly increase, but not by the same amount that has been sort of going on year, because primary prevention now is working much better. But it's more important that we look at what happens after a stroke in terms of the services that will deliver for these people. That also feeds into the staffing level. If you see 10 patients a week with stroke, but they're not seen by the specialist team, they're more likely to have more disability and stay in hospital for longer and not go home. So the outcomes for these patients, although there are more of them, they're not as good as if they go to a bigger unit. We compare ourselves to units of similar size, but as part of this, I liaise with friends and colleagues from different areas and different times to see the units that are looking after 1,200, sort of between 1,000 and 1,200 strokes, and see exactly their staffing figures, their discharge figures, and some of this data is available to the public as well on the SNAP website on the Royal College of Physicians at King's College. We're looking at, if we plan the service this way, what will our outcomes be as compared to what we have now? And the data says that we will be doing much better for our patients by moving to a single unit with better staffing than staying the way that we are at the moment. Because right now, I'm sure it's not a secret, that we're actually shifting staff between the two sites to be able to cover the medical work. So we have doctors going from Boston to Lincoln and vice versa, or mainly from Lincoln to Boston, to make sure that the patients are seen on time in the clinic and the outpatient activity continues as it is, because again, we're short-staffed again. And this is unsustainable. Like I was replying to Mr. Whittington about, you know, these locums, 2 of them just walked off when we said we need people to come and work in Boston, not in Lincoln this week. They just, you know, didn't turn up the next day. They didn't want to go there. So it is, you know, it's unfortunate, but this is what we have. This is what we have to work with.
Thank you.
Thank you, Councillor Cleaver. And just picking up on your points in regards to neighbouring authorities' ASRs, it is a concern that we have. I think we've raised this on several occasions, and we had a discussion last night with the Humber Acute Services Review, as they are slightly further behind, I think it's fair to state. Something very interesting, I think, that came out of that was some terminology they used, and that was they are not legally able to stabilise a neighbouring trust. So I think that's quite important to remember. Okay, thank you. Councillor Harrison.
Thank you, Chairman. Could you explain a little more about TIAs still going to Boston, please? When I had one, I was in Boston, the staff from the stroke ward came to see me and I was actually admitted. So in that similar case, would I now be sent on to Lincoln? Thank
you very much. That's a very, very good question, because that's another element of it that we're not changing. The TIA service depends on quick assessment, because the TIA is a warning for a stroke, and these people need to be seen. There's a national guidance that we see patients, you know, like yourself, within 24 hours, depending on sort of there's a risk element to it. So at the moment, what we do is we still run TIA clinics in Boston. We will continue to do those. The only change that will happen is the level of sort of, not severity, but there's a risk score about your risk of having a stroke following a TIA. So some of these have a lower risk, about 1 to 2% per year of having a stroke. Some of them have a 17% risk of having a stroke in the next 7 days. We will offer to see these high-risk patients the very same day or the next day, either in Boston or Lincoln. What we may not be able to offer is that they're seen in Boston on that day, because we may not have that clinic running. We will have 3 clinics per week to be able to adapt sort of patients who have strokes, referrals from GPs, people who had strokes elsewhere and have been discharged home, but they need local follow-up. So someone on holiday in Norfolk unfortunately suffers a stroke, comes back all treated, all sorted, almost back to normal life, but they need to see their local service to carry on with whatever tests or rehabilitation required. These are people who are not an urgent referral, because all the right treatment has been done, so they can be seen in 2-3 days, a week, and then they could come to hospitals closer to them. The more emergency ones, if we need to see someone tomorrow, and we don't have that clinic on that day in Boston, they will be offered an appointment in Lincoln to come and be seen straight away, as if they had a stroke, because of the high risk. If the risk is low, then what we normally do is that the person referring you, so say for example you went to your GP, our stroke specialist nurses will ring the GP back, confirm the details, and then say we need to do this and this and this and this in the meantime while you're waiting to be seen. So the treatment will start there and then, and our sort of TIA pathway is very clear and has been for many years now about what to do when you diagnose one of these people. The majority of these people are seen within a day or two, the vast majority, depending on the risk factor. When we have the clinic based in Boston, so someone, say for example, someone suffers one of these events on a Tuesday and our clinic is there on a Wednesday, you will be offered the Wednesday clinic locally in Boston. Now what I have seen in different places is that there's some kind of a reluctance from patients, sometimes GPs, to say, well, is there really any point of going to the hospital far away today if I'm going to be seen in 2 days' time here next door, and I'll just take my chances? That is something to do with sort of human factors and behavior that we can't change. You would say if there's only a clinic in Lincoln, people will turn up. I'm not so sure, because we have people who do not turn up, even with these kind of a level of emergencies. But we are planning to keep clinic services for 3 days a week in Boston, run by the stroke team, because people have strokes, and people have strokes while they're in hospital with other illnesses. And we will have our stroke nurses and doctors working on a sort of an in-reach pattern. So they will be seeing stroke patients on other wards in Pilgrim Hospital. So they'll be providing the service there on the days that there are clinics, if the patient cannot be transferred for one reason or another. So we're not completely walking out and saying we don't have any offering of stroke whatsoever. The other element in terms of outpatient activity, and thank you again for highlighting this, because I missed it, is we're planning to implement outpatient activity in peripheral hospitals as well. For example, in Spalding and in Skegness, so that we don't have to have people coming to faraway hospitals for their follow-up. They will be less frequent. They'll depend on patient numbers, but there's no point of someone going all the way from Skegness or from Spalding to Boston, or even from Gainsborough or Louth to Lincoln, if they can be seen in a clinic nearer to where they live, and it's part of the treatment closer to home as well.
Thank you.
Thank you. I've got Councillor Matthews next, please.
Thank you very much for an excellent presentation. And you clearly are doing a very, very good job in very, very difficult circumstances. However, I sense that in your presentation, you've made a brilliant case for attracting doctors to a hospital in Lincoln rather than providing a stroke service to patients in Lincolnshire. Now, I understand that you can't have a chicken without an egg, and likewise you can't have an egg without a chicken. But I want to focus on the anomaly that you referred to as Boston admissions, the very high proportion of stroke accidents, brain accidents, in an area where there wasn't a high population. There is a very, very high population of aged people on the East Coast, from Sullerby, Saltfleetby, right down to Skegness, and then coming round through the bottom to Boston. It takes 1 hour and 40 minutes to drive from my house to Peterborough, and it takes 1 hour and 42 minutes to drive from my house to Lincoln. I think that you've made a very good case for putting all of the stroke services in Peterborough or Grimsby, maintaining the provision in Lincoln and closing the provision in Boston. And I find that most unattractive and unhelpful to the people who live on the East Coast. It would be far better, perhaps, to consider putting an emergency clot-busting mobile centre on the East Coast to deal with those time-precious emergencies, and maintaining that, and then maintaining the sort of care that you currently do within Boston and Skegness and in Louth. And I think you've acknowledged the anomaly and you've just written it out. It's worse than you have said, because basically you've got no direct admission to Boston. You don't know the figures. I would like you to go back and look at the data, because I think the data is flawed. And that's absolutely not a reflection on the quality of the work you're doing and the difficulties you're facing. I want to thank you for doing all of that. I just think that the data you're using has been manipulated by the way that you've dealt with admissions and provision and support. And I think there is a far, far greater problem on the East Coast than you might be prepared to admit. And as I say, Councillor Cleaver has already raised the question, and I think it's a very good question. Should we be looking at Grimsby and Peterborough for the East Coast stroke services? Because quite frankly, we're probably getting a better deal now, and we would certainly be getting a better deal than the proposals that are being made. Sorry, that's a bit long-winded.
Thank you very much. I think in terms of the data used, I think it's a bit unfair to say that we only looked at the data after the change with COVID, because all of the data that is used in the presentation was based prior to COVID. This is these are figures that used from actual EMAS calls. I've got the page in front of me. It's page 41. When we looked at sort of each one of these orange dots is an ambulance call in terms of the stroke incidents, or 999 calls for a stroke. As a medical registrar, I worked in the sort of the southeast of England. So I was a medical registrar all over Kent, and I saw a model quite similar to us in terms of the population distribution in the sort of the East Kent. Specifically, there was 3 stroke units in Ashford, Canterbury, and Margate, and it's a very, very high population of elderly patients. I was a geriatrician at the time, and they've moved all of their stroke services. They've closed the unit in Canterbury, and they moved everything between Ashford and Margate to be able to cope again with staffing issues, even in a place as attractive as Kent. And what they're doing now is that they've cancelled that, and they're moving everything to a single unit in Ashford, and they're working on the same kind of levels of numbers as well. They have about 1,100-1,200 strokes a year that they're looking after. We use the data from SNAP, from admissions, and our local figures prior to that, because this was done as part of Healthy Conversations as well. I completely acknowledge that there is an imbalance in terms of how people get to the service. I can't correct that with this proposal or with another proposal, because ideally you should have a stroke unit, in every hospital if you can. But in the same way that we've managed to do the cardiac centre and prove that that move attracted staff, improved patient outcomes, improved length of stay, improved mortality, and that monster of prolonged journey hasn't really materialized for cardiac patients. So I don't really see it materializing for stroke patients, because we're using the same ambulance service. So in terms of data, I think the data that was used as solid as can be, because it was used prior. Data was used while Boston was still admitting stroke patients.
Thank you. I'm pleased to know you worked in Kent. I grew up in Canterbury, and I'm quite familiar with the positioning of Maidstone and Canterbury and Ashford. And Ashford sits more or less in the centre of a circle in East Kent, where it is equidistant from places like Herne Bay, Margate, Ramsgate, Sandwich, Dover, Deal, and therefore nobody on that coast is disadvantaged. And if you wanted to take, as you say, that health trust as a guide, it would strike me that you should be moving your stroke centres to Boston or to Spalding, where you would create the same solution, in that nobody inland will be travelling further than the patients on the coast, but everybody on the coast would be travelling shorter distances to a high quality service. So I think I absolutely accept that I don't understand the data, so I'm wrong to have challenged that. What I'm saying is I'm looking at the geography and the timing and the understanding that once a patient has had a brain accident, time is critical. And by moving the services and support away from the place of the accident, that is not a good thing for our residents on the East Coast.
Thank you, Councillor Matthews. If I may, I just wanted to pick up, it was a very similar question to what I had written down. And I think the report later actually picks out on page 50.2, where it states a small number of patients may not meet the time critical element to support thrombolysis. So I would like to build on with my question is, how therefore can you be confident that people are not now being put or will be put at a higher risk by consolidating this service to Lincoln? And what other mitigations have you considered? Because I do strongly feel you will have to look at things like air ambulances and actually having to be paying towards, I think, these air ambulances, because they will have to be used much, much more. So I would like to know how you've built into that, the plan.
Thank you very much. I haven't ignored the comment about the mobile stroke service, which is something that we should be looking at. Now, I'm aware of these services. We don't have them in the UK. One of my colleagues and friends, Paul Geiler from Southend, borrowed one from Bavaria, from Charity Hospital in Berlin, to use for a few months as a pilot. These mobile stroke units, as they call them, the MSUs, they're amazing. They're perfect. There's a scanner, all resuscitation facilities connected over 4G to a central sort of unit or a hospital with where you have a stroke neurologist based at all time to review these scans and see patients via telemedicine. So more or less, this is an ambulance, the same size of a normal ambulance, but it's got a scanner inside it. The kind of 4 stabilizers come from the bottom, stabilize the ambulance. The scan gets done in about 3 or 4 minutes, gets image linked to a central unit, and then the decision to treat or not to treat. These paramedics are doctors, drivers, resuscitation specialists. They can deal with lots of things. They're highly skilled and trained to do this. It's a fantastic concept. They cost about, at the time when I saw one, £850,000 a piece. But that's not the end of it. The end of it is that you have to train people to be based in that. And you could imagine the level of skill that this person will have, from driving or possibly fixing a tire if something goes wrong, to operating a CT scanner, to dealing with someone with acute stroke who might go unconscious. What that will give us as well is a lot of the time a diagnosis on the spot. So you could scan someone and find, for example, a brain tumor, and you can take them to the right hospital there and then. You don't have to take them through 1 or even 2 A&E departments for them to go to the right place. If they have a brain hemorrhage, they can go to the neurosurgical unit straight away. So the concept is fantastic. It's brilliant. I'd love to have 1 or 2. The execution, on the other hand, is slightly different. And it is part of our plan that when we get the right number of stroke advanced clinical practitioners, is that they will take part in a pilot of this, or even go and see it in real life and see exactly how it happens. The third part, which is kind of more real life, is you may get a call once a day, sometimes once every 2 days. What do you do with a very expensive piece of kit sitting in a car park in, I don't know, Skegness or Spalding, and a very experienced team of 2 people who could be doing a very good job looking after 20 patients during those days in an acute hospital, when we don't have enough people to do that? And that, that's a question I don't have the answer to, because at the moment we're short of everything. I'm not sure buying one of those will solve our current problems, but it is definitely something that we should consider and we should aim for.
Councillor Matthews, I'll allow you to come back because I don't feel that the question's even been answered. So I think you'd like to come in.
I'm sorry, as a problem solver, I'm becoming almost crosser and crosser and crosser. If you have one of those specialist services, it sounds exactly what we want on the East Coast, you don't put it in a car park in Skegness, you put it on the roof of a stroke centre in Lincoln, and you have the 2 members of staff working within your team on an operational basis where they're called away to emergencies anywhere within a 10-minute flying time from Lincoln, which massively increases your reach and ability to respond. And you're not wasting resource, you're gaining resource, and you're strengthening your central attraction, because there will be people out there who want to fly in those helicopters and be heroes and go and do that amazing service. And I don't understand why you're being negative about a solution that you think is fantastic, and it would add to your attractiveness in terms of the offer around the country. Lives have just created a trauma. It's a voluntary organisation, and they've got a trauma ambulance on the East Coast that can deal with most of the stuff that you've just talked about. They do clot busting, they do all sorts of things. One of the principal doctors is an ex-military medic, and he's brought this military technology to bear. That is staffed by doctors' lives and paramedics who volunteer their time. And they do it, and they're fully staffed. Yes, they have struggles, but it's fully staffed by volunteers. So I've got to say, I think Councillor Mace's suggestion is a really good one, and I think to dismiss it like that is unhelpful.
I'm sorry, I think we're talking about two different things. I was talking about mobile stroke units. It's an ambulance. It's not an air ambulance. I'm not aware of any helicopters scanning anybody as far as stroke care is concerned anywhere. There has not been, to my knowledge, an experiment where they fitted a CT scanner to a helicopter. The ones that are in practice in Germany and in Boston, Massachusetts, are ones that are, on four wheels using public roads. So I'm not really sure about using air ambulances. It would be lovely to be able to use an air ambulance. It cuts the time significantly, but they will have to bring these patients back to here, and we would love to have those as well if they're offered to us. I'm very, very conscious of the fact that I can only speak about things within my remit. I'm a clinician looking after patients, and I'm trying to find a solution to a problem that is not really easy to fix.
Okay, thank you. Thank you for your response. I mean, the whole reason for today is to try and work out which way the working group will go, and I think this is one of the issues that we'll want to be looking at, because I don't think it's been addressed in any way, the issues that will be faced along the East Coast. So thank you. We now have Councillor Woodliff, please.
Thank you, Chairman. Good morning, Dr. El-Mari. My colleagues have made excellent observations. I think I'm overwhelmed with the support I think that we receive from our colleagues and concern about people who live on the East Coast. I think that people would accept having to travel a bit further if they could be guaranteed a much better outcome. The problem is that travelling further on our roads is dangerous. There have been situations where ambulances have entered into ditches, should we say, on bad weather conditions, and serious injuries have occurred. So we have to be careful about travelling long distance, not like the south of East England or other places where they have good roads. Our roads around here are pretty terrible. So there is a concern about travel. I'm also concerned about the GP services, because obviously going through to a stroke essentially or whatever, there needs to be some history behind it essentially, so people know what they're dealing with. And our GP services, particularly in the Boston area, are very poor. I've had several people complain to me about the standard of service provided and people not being able to get appointments. So the initial stage is not there. Also with the ambulance service, a colleague of mine pointed out that her husband was found on the floor, having had, I presume, a stroke, and rang for an ambulance, and one wasn't available. And so she then rang back and quoted the FAST acronym against them and said, "We've dealt with the F, we dealt with the A, we've dealt with the S, it's now the T bit. It either happens or it doesn't happen." Fortunately, it did happen, and he received the appropriate treatment and survived. It's in Boston. I do wonder about the business about, does the NHS actually exist now? Since we've just learnt, if I may say, that one trust is not legally able to support a neighbouring trust. So one wonders whether the role here has been to, disassemble the NHS, so it's no longer a national body, but a series of local ones. I note on 12/2/69, page 46, lack of substantive appointments. The question is, will staff relocate to Lincoln on joining, or will they join the agency staff, exacerbating the problem? So if you might combine both units and suddenly find that you have even fewer staff because the ones who are over there decide, well, no, agency life is a lot much better, I'll join the agency. So you actually don't have as many substantive appointments as you originally had. The other question I perhaps thought is, well, what's the situation elsewhere? What's the situation in the private sector? Does the private sector do all this type of work? And what about in the European Union, over the water? What are they doing? What's the situation there? Are we worse off because we are not attracting people to the UK now? People who perhaps might have come to the UK, before Brexit, now don't come. They'd rather stay in the European Union or work somewhere else. So perhaps we've lost staff because of that. We're less attractive I do take the point about EMS, in the coastal areas. I just do wonder whether or not we have the right service for ambulance service in our area. And if there's a previous experience from my wife earlier in the year when we rang through to the NHS. My wife had her hip pop out and she was in excruciating pain. I rang for an ambulance and they said, not one available, I'm afraid. Tough. I waited half an hour and then rang back again and we did get one. Fortunately, it worked out all right. But we're in that situation where the East Midlands Ambulance Service isn't always able to deliver the service that we needed. So if time is of the essence in this particular situation and there's no one around, one might say, well, travelling by car, it might be the only option if you have one, because there won't be an ambulance available. Of course, the TIA clinics, they're afterthoughts, aren't they, effectively? They are what happens after one's had an operation. So the TIA clinics are really basically, I suppose, after operation service organisations. I mean, the point about really all of this is we know that the South Coast is an area of very high deprivation. It's particularly true in Boston, but right along the East Coast, very, very high deprivation. People live in difficult circumstances. They don't have the medical care that they feel they know they should have because
Councillor Woodliff, can you come to a question? Thank you.
I suppose I can't really. I'm faced with a situation where I think this is unacceptable, but we are in that situation. I'm only reiterating what I'm sure many, many people will feel on the East Coast, and I'm sure you know that, Councillor Macy, because you represent Skegness. What can I say? What can I ask?
Thank you very much, Woodliff. I think your comments have certainly been taken on board. In which case, Councillor Parkin, please.
Thank you. I'm going to be kind of push back a little bit, actually. When we talk about the state of the roads and travel time, we must not forget, while we're scrutinising other organisations, that those responsibilities sit with us. And so if we're here saying that the state of our roads is impeding the NHS, that's our bag to fix as a county council and not others. And I actually feel quite strongly about that we must not be passing the buck of our difficulties to other organisations. And I think those comments show that we are. And we should address those. Also, in terms of public health, I would love to know how many of these strokes that are coming through our services a year could be avoided and could be prevented if we had a public health system that was actually functioning and proactive and genuinely preventative. But again, that's a service that sits with us. Is it effective as it could be? We should be scrutinising that as well as challenging the NHS, because so much of the power to free up the resources in the NHS actually sits with us as councillors in this chamber. And, I have absolute admiration for people who rock up and face scrutiny from the NHS. But I think we need to look at ourselves as well. Are we actually making their lives any easier or not, and actually giving the residents the services that they need and they deserve? And I think scrutiny is absolutely right, but we need that within our own services and our own chamber ourselves as well. What I would like to say in the questions that I've got, obviously recruitment is a massive issue, absolutely huge here. How do we incentive? I totally get the issues about Spalding and whether it's best there, but I also totally understand why Lincoln, in terms of medics moving and relocating, is a more attractive option. What are we doing to actually incentivise not just Lincoln as a location, but Lincolnshire? Is there anything more that we can do to promote the county as a brilliant location for medics to move to, cheap housing, great way of life? What is it that we can do to promote a sense of place to try and get people to us, because we are an unknown. If you're working in a city hospital somewhere, what is it about what we have to offer that could bring people over? And I think in terms of the transport as well, I actually think that most people are mature enough and understanding enough to recognise that in an acute situation that there may be a problem visiting. I know that we've had that as a family as well. But I think what they won't accept is a massive, massive impact in terms of their quality of life in the medium to long term afterwards. And so it really is about, for me, that aftercare being as close to home as possible for people so that they can return to normality quickly, because otherwise I think the trauma of the incident and the psychological impact for themselves as patients and their families just remains.
Would you like to come back on that?
Can you hear me? I lost your screen.
Yeah, we can hear you. If you'd like to come back on that, please.
Okay, I'm just lost the screen, so I can't see you at all. In terms of recruitment, you know, the sort of I'm trying to amalgamate the comments from both councillors in one. Nobody does this job just for the money. Nobody, you know, wants to become a doctor or a nurse just so that they get paid at the end of the month. There's a lot to it, more than that, and most people want to do their best, and if not all, people want to make sure that a patient's life, that, you know, this is out of this meeting, but I tell my medical students one thing is that they're so special because they have that gift of changing someone's life or saving someone's life every day they get to work. Not everybody gets that opportunity. Even the richest people in the world can't do that, and they have that. So there is a dedication to it. And yes, there are a few rotten apples in every, you know, profession, and there are people who are more interested in themselves and what they can get out of the job. And we get these everywhere. We get more of them when there's shortage. But normally most people are, you know, decent, and they try to do their best for their patients and their colleagues as well, because that's another important element of what we do. We work as a team. Stroke care in general is a team sport. The doctors make few decisions at the beginning, but then they're less involved. It's the therapists that make the decisions about whether someone can eat or drink, or what level of activity they can and can't do, what consistency of food they can eat or drink that they can drink. It's a multidisciplinary specialty in every sense of the word. So we work as a team, and our therapy team has won a national award recently, I think in the last few weeks, for the way that we work with our community, between community and the Acute Trust. Since the Healthy Conversations, we had the 100-day challenge, which again is included in the paperwork that's available to you as well. And being able to work to see things from the other angle opened our eyes to the difficulties that this team, because we just thought, why don't they take our patients? What's wrong with them? And we understood each other's difficulties, and we worked through solutions to make life easier, first and foremost for our patients. Attractiveness. This sort of comes to some truth. Some of them are inconvenient. The stroke team that ran the stroke unit in Boston consisted of 4 consultants. And I hope you don't, you know, take this the wrong way, but Maltese, Croatian, Bulgarian and Romanian. And I was told after the Brexit vote, why did people not like us? And one of them was planning to leave the trust, unfortunately not left. But that is one of the elements where you think of us as, you know, sort of the Brexit central, about how people perceive that. Now, I am, you know, a practical person. I try to provide solutions, and I try to work with people to make sure that our patients get the best care. So it doesn't bother me one way or the other. But it is very important to understand the context of humans providing a service to other humans. And it doesn't really matter to the patient who's looking after them. It doesn't matter to the doctor who they're looking after. And one part of the attractiveness has to be looked into in total. It's not the roads, it's not the cheap houses. You know, being trained, like I said, I trained in South London. It is attractive, of course, to stay in a big city near to the airports. near to everything, have a life, go out, do whatever you want, be close to people, that train, feel a connection with. But I am conscious of the fact that it is difficult to attract people to this part of the world, and we're doing our best. And if we find, which we have found, that one place is more attractive than another, then I don't really see the problem with trying to get people wherever I can base my service.
Okay, thank you for that answer. No further questions apart from one from myself. So my question is, one of the reasons for the consolidation is the difficulty recruiting and retaining staff across the two sites. The proposal as set out in the papers appears to work on the basis that the staff currently working at Pilgrim will move to Lincoln to mitigate those shortages currently experienced within the stroke service. However, what is the plan should this not happen in practice and you end up simply short of appropriate staff on one site as opposed to two?
Yes, and that is something we have thought about, because we know people have schools, gyms, an elderly parent living next door. They're not really just going to move in their drove just because, the job has moved. So we're moving the posts, not the people. The people will be very important to us because they have the skills. And if they can't move, then, they will have to do what's best for them. Moving to a single unit will make it more attractive for people coming from outside as well. So in a way, it's a win-win. People get to stay in their preferred place of work, and we get someone else to come in to fill the post. So we're not short on both ends. This is another human factor. So people will have to make a choice whether they want the job that they're trained for, that they love, that they like, but 30 miles down the road. We have people coming to work with us who live not only in Nottingham but in Chesterfield, and they drive every day because this is what they want to do. Or do they want just to sort of make life a priority and stay in a place where they feel more comfortable and do a job that's slightly different? I don't have a solution for that at present until we know exactly what's happening. We're in a consultation. We don't know what the outcome is. If things go with the preferred option, then everybody will be offered their job. The other element, obviously, to this is we will need fewer people than what we have at the moment in total. So we have 28 beds in Lincoln, 24 beds in Boston. We're working on a bed base of 35 beds with an enhanced community service. So we will need fewer than the sum total of what we have at the moment in terms of therapists and nurses. Doctors, unfortunately, we need the same, if not more.
Thank you for that answer. I think turning around what you said earlier, my issue is the fact that you said that these consultants are like gold dust. So moving it to one site, I understand it may be more attractive, but it could quite simply also lead to an issue that you can't staff it in Lincoln either, and we end up without a service full stop. And I think that's something that is not addressed in any way throughout this. So that's the last comment I'd like to make, and I do think it's probably time now to move on. So I would like to thank Dr. El-Marimi for his attendance today. It's been very, very useful, and we do truly appreciate your time. We know you're incredibly busy. I'd now like to move to a proposal that we note the details presented on the Lincolnshire Acute Services Review of Stroke Services, to record the committee's initial findings on the proposal for consideration by the committee's working group, and to highlight any areas which the committee's working group might wish to explore in further detail. I do think some of those have been pulled out within the meeting today. I don't know if there's anything specifically any members would like to see added for us taking forward. No, that's fine. Simon, I think we've got a good steer there to take forwards. Thank you. Do I have a seconder for my proposal? Thank you, Councillor Wootton. And all those in favour, please show. Thank you, that's supported unanimously. Once again, thank you to Dr. El-Marimi. We'll move on to agenda item 6, the Lincolnshire Acute Services Review, Urgent and Emergency Care, which you'll find on pages 61 to 92 of the agenda pack. I'd like to welcome our presenters via Teams, Dr. Dave Baker, South West Lincolnshire Locality Clinical Lead for the Lincolnshire Clinical Commissioning Group, Dr. Yvonne Owen, Medical Director for the Lincolnshire Community Health Services NHS Trust, and Charlie Blythe, Director of Communication and Engagement for the Lincolnshire Clinical Commissioning Group. I'd like to hand over to you to about 10-15 minutes presentation and then to take questions at the end, please. Thank you.
Hi, do you want me to make a start? So I'm Dave Baker, GP in Grantham. I'm also clinical lead for the South West Links part of Lincolnshire CCG. I'll take the paper as read. I know you're running a little bit behind. As you're aware, there's been a lot of concern regarding the future services at Grantham for forever, really, certainly for many, many years, particularly regarding the future of the A&E department. And you'll all be aware of issues we've had over the last few years with recruitment, not just at Grantham, but across all 3 sites. And we still do have ongoing issues across those sites and also at Grantham. Both the consultants at Grantham are locums, one's actually retired and come back. We've got other staff there that are locum staff or bank and agency staff. So the problems are ongoing. You'll also be aware of changes that were made in 2016 that resulted in the overnight closure of Grantham A&E, and that's still in place 5 years later.
Sorry, Dave, can I just stop you for a minute? It's incredibly hard for us to hear in the chamber. It seems incredibly sort of distorted and tinny from your side of things. I don't know if it's RIT, I assume not. I think we're being told it's coming from your end. I don't know if there's anything you can do just to sort of dampen it down somewhat.
I'm not sure I can actually. Can you hear me now okay or not? Or is it still very tinny?
It's very tinny, I'm afraid.
Shall I log out and then log back in again, see if that helps?
Yeah, I think it's worth a try, certainly.
Yeah,
thank you.
okay.
Sorry.
No.
Do you want me to pick it up?
If you would do, I can hear you perfectly. It's just in the chamber, it's even harder to sort of hear it. I don't know what it's like actually on the team side of things, but it's not anything we can particularly hear.
No, it's difficult. Well, if you can hear me, that's fine. I wasn't sure if I was online because all I can see is 2 of David. can't see anything else. David, you're back now.
Can you hear me now?
No, it's the same problem, I'm afraid.
Right, it must be a problem with the internet connection, but I'm actually at work, so it's usually really good.
Okay.
I can't make that out at all. I'm sorry, Dave, but we can hear Yvonne perfectly.
Shall I'll carry on then, David. I mean, interestingly, I can hear you okay, so it's difficult to know where the problem is, isn't it? But I'll pick up what David was basically saying, which is that for the last 10-15 years that there have been difficulties in terms of providing what is recognised as a level 1 A&E service on the Grantham site. There isn't the full complement of specialist services on the Grantham Hospital site to be able to support a level 1 in A&E. And what I mean by that is that if you are providing a level 1 A&E service, then essentially you should be able to provide whatever could potentially be needed by a patient from birth up into the kind of 90s, 100. So both extremes of age and everything in between. And you should also be able to provide the initial treatment that's necessary for whatever that patient may present with, be it a medical problem or a trauma related problem. And quite clearly over the years, what has happened at the Grantham site is that services have been moved for a variety of reasons that I think is out of the scope of today's discussion. But essentially what we now have on site at Grantham is acute medicine. There is an element of anaesthetic cover, But what we don't have is we don't have paediatrics, we don't have gynecology and obstetrics, we don't have surgery, we don't have acute orthopedics or ENT or stroke medicine or acute interventionalist cardiology. So in terms of the range of specialist services that are required to support a level 1 A&E, they aren't there. And as a result, what has happened over the last few years is that patients who have attended Grantham as an A&E department, who have required those services, have had to be transported elsewhere, either to Nottingham, Lincoln, Peterborough, depending on what their need is and where the available services are. More recently, there have been difficulties with staffing the A&E department, and as a result of that, the decision was made to reduce the opening hours from 8 o'clock till 6:30 in the evening. So in addition to not being able to provide the full complement of specialist support services, the actual opening hours have been restricted. And when we started this work looking at, what would be the best solution for Grantham, probably 5 or 6 years ago now, it seems to have been going on for an awfully long time. We took those things into consideration, and what we particularly wanted to do was come up with a solution which would provide a kind of permanent, sustainable solution for Grantham, because the people of Grantham, the staff at Grantham, have lived with uncertainty for an awfully long time. And, now is the time when they need certainty. They need to know what that service is going to look like. And in particular, they need to know that that service is both clinically safe and economically viable to survive into the future. And certainly when the East Midlands Clinical Senate looked at urgent and emergency care at Grantham, what they essentially said was that, there isn't the facility and the requirement to provide a level 1 A&E. However, there is a need for an urgent care service, and I suppose based on our experiences across the rest of the county, we feel that the best solution for providing urgent and emergency care to the population of Grantham and the surrounding area is to transition to an urgent treatment centre. And in response to feedback that was received after healthy conversations took place before COVID happened, that has been expanded to be a 24/7 service, which is accessible both by walking through the door, but we would also encourage people to talk before they walk. So utilising 111 and the services of CAS, there will also be the ability to book appointments. So rather than just walking in and waiting, there will be the ability to pre-book an appointment, so that people are less likely to have to wait to be seen, managed, and then hopefully discharged. The proposal is that the UTC would be provided by the community provider. Within Lincolnshire, this is LCHS, and LCHS does provide all of the UTCs at Lincoln, Boston, Gainsborough, Louth, Skegness and Spalding, and certainly at the moment is providing a significant diversion of patients away from ED on the Lincoln and Boston sites, which is, keeping flow going as well as we can expect really at this time of year. one of the advantages that we found with the other UTCs is because they use the same clinical software as the majority of GPs in Lincolnshire, and particularly in the Grantham area. It means that the clinicians who see patients within the UTC will have access to the GP record, and vice versa. The GP will also be able to see what's happened to the patient if they have attended the UTC at Grantham. So in terms of a kind of holistic approach to patient care, we believe that because an attendance at a UTC would be part of the patient's healthcare in general, rather than a kind of isolated visit, which is what tends to happen if you go to an emergency department, because it's really difficult to get any detail of that visit. Then we feel that this is very much an improvement for patient care. From a staff perspective, I think removal of that uncertainty will help in terms of keeping staff on board, retaining them, any future recruitment that's necessary, and certainly after discussions that David in particular has had with Health Education England, they are really quite excited about the opportunity at Grantham to develop almost a specialty of rural healthcare. Because it is very different providing acute healthcare in a county like Lincolnshire compared to a very high population urban area. So this is, looking to the future, we strongly believe that we will be able to recruit and retain the workforce that is required to provide this service, which is, where we get that sustainability from. David, I don't know if you want to come in at this point and add anything.
The joy of technology, I'm afraid.
I can't hear anything.
No, it's not coming through at all now, but that's not a problem. If it does come through, by all means, Dr. Baker, just let us know and we'll try and get you to allow the mic. Okay, before I move into questions, I've just got one myself, so if I may, which is on page 66, under the heading Opportunities. It states that changing to a UTC will improve our ability to attract and retain talented and substantive staff to an effective, high quality, successful and sustainable service. My concern with this is that I'm aware that for several weeks, LCHS have struggled to cover staffing levels in other UTCs across the county. One example is Skegness, where they often have not had on-duty doctor for days. They regularly only have 2 nurses to cover, and in turn, members of staff have been sent to prop up services in both Louth and Pilgrim. So how confident are you that this service will be truly sustainable and that it won't be, within a matter of weeks or months, only available between 8 AM and 8 PM, providing the minimum UTC service due to staff shortages?
Okay, and I mean, certainly specifically from an LCHS perspective, I can answer that question. The difficulty with staffing is nothing to do with the model of care. It's being felt right across the NHS, so in acute services, in general practice, in all community services, and it's purely related to illness and to the need for isolation if somebody within your household becomes COVID positive. So any staff shortages that we've had, and I would question whether we've gone for days without a doctor. We have had occasional shifts where a doctor has gone down at short notice due to illness or due to a need to isolate or get tested. But one of the, I suppose, the strengths and the resiliencies of having a county-wide service is that we are able then to be quite constructive with our staffing to make sure that services maintained as much as possible, and certainly in terms of, you know, standing down availability of the urgent treatment centres, that has not had to happen because we have been able to cross cover. So I would say again, this is a temporary issue that is being felt across the whole of the health service, and I would imagine in other public services as well. It's not just in health, and is not related to the UTC model. It's largely down to COVID.
Okay, thank you. The word temporary always makes me nervous. I've got Ray Whitman first, please.
Thank you very much indeed, Mr. Chairman. Mr. Chairman, there are dozens of pages in this report, and there are so many questions that I want to ask that I could be here all morning. What this report does not show or state is the views of the real people of Grantham and District. John Turner said, the chairman of the CCG, said in his report in the Grantham Journal this week that we are listening, and that by completing in the consultation period, you have the opportunity to influence what will happen. Well, within this report, I do not see any notification of the motions that District and councillors put by myself and Councillor Whittington have been made, fully supported at both councils, that we wanted to retain A&E at Grantham. It also misses out on the 60,000 petition that we took to Downing Street. It also misses out on the numerous rallies. Thousands of people walked through Grantham saying that they wanted their A&E to stay. And it also misses out on the campaign group's views throughout the district and Grantham. So I'll ask Dr. Baker, are you listening, Dr. Baker, to those views?
Hi, Ray. Can I just check whether you can actually hear me normally now or not?
Yes, we can.
Brilliant. Okay. Hi, Ray. We've had these conversations many times, haven't we? I think the difficulty, I think we are listening. One of the things that came out loud and clear when we did Health Conversation 2019 was people wanted a 24-hour service where they can walk in. So we've certainly changed our proposals so that it is now an open door 24-hour service. I think what we can't do is offer something as an option that we actually genuinely cannot provide. I'm personally of the view that Grantham hasn't provided a full A&E service for many, many years, probably 15 years at least. And that's for one really simple reason, actually. I missed quite a lot of what Yvonne was saying, because obviously due to the I'll blame the NHS technology rather than countless technology. But Grantham doesn't have that breadth of services that you actually need to support an A&E department. So while we've got medical beds, we haven't got paediatrics, we haven't got acute surgery, we haven't got obs-and-gynae, we haven't got ENT, we haven't got emergency ophthalmology. Now, to provide a proper A&E service, you have to have the supporting services for that A&E, which we haven't. You know, I'm sure a lot of the public would say, well, we should. Well, the situation is we are where we are. We have not got those services. And realistically, they are not coming back anytime soon. So for us to say that we're offering an A&E service is I think it's wrong. I think it's misleading, actually. And what Grantham's provided for many years, in my view, is a very large and very good urgent treatment centre type service, not an A&E service. And we've been told by external bodies, ESIS, the Clinical Senate, that actually it is wrong of us to be calling Grantham an A&E service, and have been wrong for a number of years when it isn't. So, you know, I think what we've developed is a really robust model, a 24-hour model that's got the right mix of staff that we need to deal with the vast majority of the patients that come to Grantham. So you'll see in the report, we're suggesting this model can provide for 97% of the people that currently come to Grantham. And actually, from a medical perspective, there are small numbers of people that come to Grantham that actually shouldn't. So that's, 2-3%. They're far better served actually going to a hospital that's got other services to back it up, such as critical care services. And, if I've got, if tomorrow I develop severe sepsis, please do not take me to Grantham, because I've got a far better chance of survival if I go to Lincoln or to Peterborough or to Nottingham or to Boston. So I think for me, this is the right proposal. This is the right service for the people of Grantham. I'm a Grantham resident, so I want my services to be the absolute best they can. And I think this is the right model. And I'm sorry though, we cannot put to consultation a model that is impossible to provide. And a full A&E service in Grantham is impossible to provide.
Okay, thank you. Charlie, you'd like to come in, and then Ray, if you'd like to come back.
Thank you. Yeah, Dave has answered that clearly from a clinical perspective and made the really key point about making sure that all proposals put forward are deliverable. But just to come back to Councillor Wotton on the petition and the acknowledgement of all of the strength of feeling that has been demonstrated by Grantham's residents on a process point of view for public consultation, and to give some assurance. We did touch upon this last month, and in terms of capturing the information that's coming through via this public consultation or what's gone before, that's a really important part of the process for us. So every comment, feedback, every questionnaire completed clearly, and then additional surveys are all captured and recorded and will be analysed throughout this process, and at the end by the independent body that we're working with, so that that can inform the decision-making process at the end of the consultation. A really important point to just recap on, though, is appreciating the sort of, whether it's 6,000, 60,000 or however many that reply and state a very valid point that an A&E is important to them. We can't push forward a proposal that is undeliverable, and it doesn't come down to the numbers, and I think that's an important point. But what is really important is that a single statement or a single observation from a member of public or a stakeholder that gives us a line of inquiry that might lead to something viable, might alter the model or proposal, is something that we're committed to looking into. So a good example of that being in the prior conversation, we talked about this mobile stroke unit, and Mr. El Marimi talked about it was something to be looked into. So my role here will be to take that piece of information back to the team to make sure that that is appropriately considered and reviewed as part of the consultation process. So whilst Dave has given a really clear clinical rationale as to why the proposals are as they are at the moment, I just wanted to add into the process that we're going through, and to give some assurance about how we're capturing and making sure that we're using this tangible, substantial information that's coming back to us. But as a reminder that it won't be about a numbers game in terms of how many feel for and against, because ultimately that may not mean something is any more deliverable as a proposal. Thank you.
Yes, thank you, Chairman. Thank you very much indeed. What I don't recognise within the report is that you're saying a substantial number of people want a UTC, but they're not the people that we're talking to. And also within your report, you're saying that if we have a UTC in 23-24, 39,000 people will be using that. Well, if there's a demand for that, there must be a demand for an A&E. And also, which I think is important, Chairman, is travelling time. There's reports here that 400 patients will be going out of the county. That must be taken into account, surely. There's demand there. Thank you, Chairman.
Thank you, Councillor Wotton. We'll move on to Councillor Parkin, please.
I have to say that there's a deep irony about this agenda repack, because last agenda I read in Grimsby A&E with my daughter in hospital with a kidney infection, and this time it was Louth Urgent Care, where my son was in with a suspected, well, it ended up to be sprained wrist. So it did strike me as incredibly ironic that for both agendas I actually read them waiting for treatment in A&E's and urgent. You couldn't make it up. I just want to make a pitch in defence of urgent care centres and their use. Obviously, in East Lindsey and in Louth, we are well used to that model. And in fact, in Grantham you are too, because it is in effect what you've got now. And I think where I'm looking at it from a, you know, let's take it from a kind of completely personal level in terms of, you know, my mum hat on rather than my counsellor hat on. I do not want to necessarily send my kids into A&E unless I have to. Okay, I don't, because they're going to be exposed to things there that you don't really want your kids exposed to. But I also recognise that there is a need for somewhere to take my kids when they do what my son did on Monday and go flying into school, and, you know, that the GP also can't fix. So for me, from a pragmatic, and that is true for a whole range of conditions. So in terms of that next level up, I will defend the place for UTCs in our healthcare system to the hilt, because it means that we have an easier and a more local option that spares us the trauma of, not in a medical word trauma, but spares us that experience of A&E, which can be difficult and can be traumatic, can be incredibly time consuming, and it takes pressure off those A&E services. Now, I have every respect, Ray, for the campaign that you have launched and helped with in Grantham. Every respect for that. And, you know, I take my hat off to you as a councillor for it. But I don't know how that is deliverable. When you talk about an A&E in Grantham, and having read through this report, sadly, I have to agree that it would be lovely to have, it would be great to have, but I'm not sure we can. And when you think of the funding issues that have come nationally from central government to this, it's like me saying that I'd like, you know, a Gucci handbag and all the rest of it. Well, you know, I can't, because I haven't got the resources for that. And that is really difficult, and it's a really painful pill to have to swallow when you are in that area and you love those people and you love that. I get the pain for that, for the community, but this problem has come from and is a problem of national government and national funding for the NHS. And again, you know, it is about a political wake-up, I think, as well as doing the fantastic job that you have done about representing the community, because you've done a fabulous job. But I don't see, you know, we are where we are because of resource issues and because of finance issues that have seen the NHS strapped. And I'm not sure how we in this chamber can dress it up in another way. And as I say, that's no disrespect to you at all in the work that you've done locally.
Okay, thank you. Councillor Parkin, would you switch your microphone?
Oh, sorry.
Please? Councillor Whittington.
Thank you very much, Mr Chairman, and thank you very much, Dr Owen and Dr Baker. I actually want to sort of pick up the aspect of A&E at Grantham, obviously. Now, when I worked at Grantham Hospital between 1996 and 1998, it had a full level 1 A&E. It also had all of the support services behind it. You know, it had natal services and obs and gynae and peds and trauma and theatres and general surgery and all that sort of stuff. At that time, Grantham Hospital was an independent trust, as was Pilgrim and as was Lincoln. And at the same time, both Lincoln and Pilgrim, as self-contained independent hospitals, were offering, obviously within the NHS framework, but as individual NHS trusts, all three were offering full range of services. For me, the problem seemed to develop when the idea of the ULHT was brought about and the three hospitals merged. Because ever since then, there has been, as has been picked up in the comments, a gradual seeping away of services from Grantham, you know, and it is very much a domino effect, you know, and I accept the fact, as somebody who has worked in the NHS for over 25 years, that there are linkages between services. You know, unless you've got a theatres service, you can't have a trauma service, you can't have a general surgery, you can't have a obstetrics and gynecology service because you can't do the obs and gynae surgery you need. You need to link things like natal services with obs and gynae and with paediatrics. So I get all of the linkages and the fact that once you start losing services, it does become a domino effect, and rapidly, because of the interconnection, you lose more and more and more. And in effect, that's what's happened to Grantham Hospital over the past 20 years. It's been hollowed out. Now, I think that Councillor Parkin, when she talks about the resource issue, I think the resource issue is one very, very important aspect and part of that. But also, one aspect that I think maybe I just need a little bit of sort of comment on from Dr. Owen and Dr. Baker is I'm very much aware that as new treatments come along, as new ways of working in the medical profession come along, the standards and codes that the Royal Colleges expect of surgeons increases all the time. So in many respects, increasing standards and requirements, in effect, almost naturally lead to a situation where the smaller units, and I think that we've explored this point with stroke earlier on, the smaller units can't offer, can't deal with the increasing level of the standards and requirements that's sort of come out from the Royal Colleges and the medical professions. So some comments around that would be really useful. And it's also in terms of locums, I mean, when I worked at Grantham Hospital, we had no staffing issues. We got all of our locums came over from Nottingham or Leicester because we were fairly close there, and we could draw on locums from there. So some comments around that, I think, would be quite useful. My second question, I'm still picking up concern from local residents, and I think I'm referring to, I think Dr. Baker said, the 2 or 3% who won't go to Grantham now, but will go to either Boston or Pilgrim. Sorry, Boston or Lincoln. Sorry. Now, obviously, if you get admitted into A&E via those particular routes and end up on the wards at either Boston or Lincoln, potentially when you're discharged, if you don't have transport of your own, I believe transport can be arranged. But there seems to be an anomaly for those patients who may go to A&E, receive treatment, aren't admitted, and then potentially could be out of A&E at the middle of the night. If those that don't have access to a card themselves, or if, because obviously they won't have driven themselves there, if the family members aren't available or they don't have cards, and actually this will disproportionately have an impact on those people because car ownership is linked to relative wealth. And so potentially people who are already deprived, don't have a car, get released in the middle of the night, say, after being treated, are faced with a very expensive taxi fare back from either Lincoln or Boston to Grantham area. And these are people who don't have a great deal of money anyway, so we're putting a huge financial burden on them as well. So I'm just wondering what help what we can look at to do with that. And I pick up again a good point that Councillor Parkin made in the previous thing on stroke services. Part of this could be what can LCC do to help to potentially mitigate that situation as well. So I'm not saying it's entirely NHS issue, but so some comments about that and if some thought could be given to kind of dealing with that. And then my third point is around the waiting times at A&E, because we seem to have got, I don't hear a great deal mentioned anymore about the old 4-hour wait inside A&E. I think it's been dropped. But my concern is that it's not just the waiting time in A&E, but I know at both Lincoln and Boston there's also a substantial amount of waiting time in the ambulance before you even get into A&E. So I think that's a real issue, because potentially there's been instances where we've known patients have been in the ambulance outside the A&Es for an hour and a half, 2 hours, then have a 4 or 5 hour wait. So I'm just wondering, what pressure more patients going to either Lincoln or Boston will have on those waiting times already at Lincoln and Boston. What's generally happening around waiting times? I'll be really quick, Mr. Chairman. This is my final one. On page 74, at 10.2, 10.2.9. And this talks about the point that the UTC being available 24 hours a day, 7 days a week, and will accommodate walk-ins through the opening hours. Then in brackets, it says, though the preferred route of access will be via NHS 111. So we seem to have a conflict there in the paper, saying, oh, it will be a 24-hour, 7-day-a-week walk-in, but the preferred route of access will be via NHS 111. To me, that is sending out a mixed message. And that's probably why Grantham patients who ring 111 aren't being directed to Grantham, but being directed elsewhere. So I still think in the document itself, there still seems to be this mismatch between what is being said and what actually appears in the documentation, and potentially is going to cause issues and problems, and especially because the 111 service may not be aware that Grantham Hospital will accommodate walk-ins and may direct patients elsewhere. So I really do think that needs to be tightened up, because at the moment it's contradictory, and if I'm struggling to understand it, I'm sure it's going to have, residents are going to have problems as well. Thank you, Mr. Chairman.
Thank you. I think we've got Yvonne first to speak.
Yes, apologies. I had to just dip out there to see a patient, but I'm back now. So I missed the first 3 points, but if I could pick up on the fourth and the fifth point that the councillor made. So first of all, the 4-hour target, it hasn't gone. So all A&E departments and indeed UTCs are still measured against the 4-hour target. As you say, at the moment there are significant delays, both in terms of ambulances being able to offload patients and patients then being seen, treated and either admitted or discharged. That is not a problem that is confined to Lincolnshire. It is across the UK. There are a number of reasons for this. What I can say in Lincoln and Boston departments is that a significant amount of the increased activity that we're seeing in urgent and emergency care is actually being managed within the UTCs on those sites. So they are seeing as many patients as they possibly can, including ambulance patients. And whereas, the average 4-hour target achievement in our A&E departments across the Midlands is running at about 60–70%. Within our UTCs, we are consistently hitting the 95% or just below the 95% target. So despite the fact that we have seen a massive increase in activity over recent months, we are still managing to see treat and discharge 95% of our patients within 4 hours. Now, that's obviously because our patients are less complex, they're less likely to be needed to be admitted to a hospital bed. And the problem really with ambulance handover is largely due to lack of flow. So if you don't have any empty beds, then you don't have anywhere to put patients, and therefore you can't just keep taking people into the department because you haven't got the flow to move them through. What we know about the majority of patients who attend Grantham A&E, and Grantham has consistently been meeting its 4-hour target, is because they are less complex. Because if they do have complex needs, the likelihood is that they will need to be transferred elsewhere because those services aren't available on site. Then we don't tend to get the backlog. So we are confident that that the achievement of the 4-hour target will continue if Grantham becomes a UTC. Going on to your point about in the consultation document, it talks about 24/7 walk-in, and certainly that is what we have worked on following the feedback that we got from the public during Healthy Conversation, because that was obviously very, very important to them. The reason that we say, it's a good idea to ring 111 first is not because we're trying to put people off walking in, but if you have chest pain, then you need to be in the heart centre. You don't need to be in Grantham UTC. And if you ring 111, they will send an ambulance to take you straight to the heart centre. Whereas if you decide to walk in, then that is inevitably going to delay you receiving the treatment that you need. So it is very definitely a 24/7. But if you're not sure whether, you know, you need to go to the UTC, you need to go elsewhere, or actually this can wait so that you can see your GP when they're available, then ringing 111 is always a good idea. And as I said earlier, you would have the ability to book an appointment. So if it's not convenient for you to go now, then, you know, you would be able to book an appointment for later on in the day when it was more convenient. So hopefully I've covered those 2 points. Dave, I'll hand back to you for the first 3 points because I didn't hear those. Sorry.
Thanks, Yvonne. Councillor Richardson, I think you started in terms of the changes that have happened in services since you were there. I think it's in around 96. I came to Grantham in 92 and went straight into working at the hospital. So I worked in quite a few of those departments that are no longer there. And I think we'll all know part of the reason why some of the services were removed initially, the sort of sad events around what was Ward 4, the paediatric ward at the time. And it has been a bit of a domino effect, I think, over the years. What I would say, though, is I have to say I don't lay the blame at ULHT, which you may find a little surprising. I think a lot of these things would have happened anyway over the course of 30 years. And I think you touched on it a little bit. You know, medicine does change. We advance and we find that actually many people are better served at centres that have got a wider range of backup services. I remember I think it would have been around 98 when they decided to take the acute surgery service away. Now, interestingly, I campaigned against it because at the time I was concerned about the erosion of services at what is my local hospital. But sort of thinking back, I remember the reason for it. David Valerio, who was the head surgeon, who I have enormous respect for, is now retired. But at the time, they were only doing 3 acute operations a week. Now, it's pretty clear now, looking back, that how can surgeons maintain their skills and competences if they're doing, and this is the whole unit, 3 acute operations a week, and the answer is they can't. And David at the time said he didn't feel this was a safe service any longer, and that was the reason that the ULHT made the decision. So it wasn't on finance, it wasn't a political thing, it was nothing to do with government. It was actually the surgeons themselves, the lead surgeon himself, who really sadly, because he'd worked there for many years, felt that service was no longer sensible, stable, viable to continue. And that's where we are. And other services, unfortunately, have gone over that 30 years. If you look at the guidance for the Royal College of Obstetrics and Gynecology, they suggest that an obstetric unit should really be delivering around 6,000 children a year for adequate training and for people to keep their skills up. I remember at the time Grantham was delivering around 1,400 babies a year back in the early 90s. Now the population has grown, but we'd probably still only be looking at 2,000 maybe. So it just wouldn't be the new guidance really that the college has set. So it isn't. It's not practical that these services are going to come back, and because of that, as I said previously when I was responding to Ray, you can't run an A&E service without the backup services. I think what we have developed though, which hopefully will reassure Ray to some extent, is quite a bespoke service for this urgent treatment centre proposal. So we recognise that actually, because we've got medical beds, and we'll be discussing in December, we're retaining the proposal to retain acute medical beds. Actually, Grantham can take a higher level of acuity than some of the other urgent treatment centres. And that's why we get to this figure of 97%. So only the people, the really sickest people with what we call, we use something called a new score. So people with very high new scores wouldn't be able to come to Grantham. And actually, these are the people that when they're taken to the hospital, they're not going to be sent home in the middle of the night because they're ill. They're going to be admitted and they're probably going to be in hospital for many days. And sadly, some of them may not make it as well, but they're not going to be asked to get in a taxi in the middle of the night and come home. I do think transport's an issue, clearly, because some people, for a variety of reasons, will be directed to Lincoln and Boston as they are now. So if you've got an acute eye condition or an ENT condition, things that Grantham hasn't got the specialists on site to deal with, you already have to go to those sites. And that may mean that you do have to try and find transport late at night. And I absolutely agree. I think we do need to find a transport solution for those people, something we've I think, sadly failed to address over the last few years. So that certainly needs looking at. I'm not sure whether I've covered everything, Councillor Whittington, but I'm happy to come back at me if you've got any other questions, really.
Yes, thank you, Dr. Baker. I think you kind of, in your answer, kind of answered the point I was sort of going on about unfortunately, it's not just a finance issue at Grantham, but standards in the medical profession have increased, and the Royal Colleges, do have new operating models and things, and I'm guessing that the direction of travel over the last 25 years has been towards larger units. I think maybe perhaps if it, so I think you answered that point. In terms of the transport, I think it is an issue. Maybe people just need to try to do a bit more thinking about just trying to help those patients who may just be released, in the middle of the night or difficult times of day, and haven't got the financial resources to get back home. Just to try to work out some solution. And here I'm thinking that perhaps the county council has got a role to play as well. Thank you.
Thank you, Councillor Whittington. I've got two more speakers and I'm going to close the debate down because I'm conscious of the time. So I've got Councillor Linda Wootton next, please.
Thank you, Chairman. We've been talking about this for years and years, and it's a very contentious issue for us local councillors. Councillor Whittington's actually covered one of the questions I was going to ask, so I'm just going to say thank you for the presentation, thank you for the paper, and Dr. Owen started her conversation by saying we won't get a level 1 A&E. Well, we haven't had a level 1 A&E for years and years, and that's because we've lost the services, so we were stuck at a level 3 A&E. So my question will be, how is UTC different to a level 3 A&E? And also, as covered in the paper, what is the plus to the UTC unit? And I've spoken to Dr. Baker in the past, and he's always said to me, we're going to be better than a UTC, but can somebody explain to me what the plus is and how that is better? And Dr. Baker, I think you're sitting in a cupboard because we can't really hear you very well at all. But thank you very much, Chairman.
Okay, I think particularly if you're not hearing David particularly well, then if I could try and answer that question. So the first question, how is a UTC different to a level 3 A&E? Well, there isn't a difference. It's just a different name, basically, because I've already talked about what the requirement is to provide a level 1 A&E service, and for the various reasons that have already been mentioned, that there isn't the ability to provide a level 1 A&E service on the Grantham site as things are at the moment. So a level 2 A&E is actually a specialist A&E, so something like an eye casualty or an ENT casualty. A level 3 A&E doesn't really exist anymore. And I suppose, you know, that's part of the reason why they developed the concept of a UTC. Now, the reason that we talk about a UTC plus is basically because if you look at the national specification for a UTC, then it talks about coughs, sore throats, minor sprains, minor cuts, and that gives the impression to the public that, you know, unless you've got a problem that actually could probably be managed by a first aider, then, you know, you're not going to be appropriate to attend the UTC. What we already know in Lincolnshire, particularly on our Lincoln and Boston sites, is that, you know, we manage a range of patients that are well above those presenting conditions. So we do manage people who are acutely unwell. We do arrange direct admission to hospital when that's appropriate, or direct referral for diagnostics. And we do manage patients who've got uncomplicated fractures. You know, we have X-ray facilities, etc., and none of that will change. So I suppose in terms of what's the plus is what we would be doing above and beyond the national specification, and we already have significant experience of doing that. On the Louth site, the Skegness site, and in particular the Lincoln and Boston, because as I say, the necessity over the last few months is that, you know, we have had to upscale acuity in terms of the patients we're managing, simply to cope with the number of people who are trying to access urgent and emergency care.
Okay, thank you. And even more interestingly, I've just been told Skegness UTC is closed today due to staff shortages. Okay, Councillor Matthews.
Thank you, Chair. It's a point of order, really. Skegness UTC is closed due to staff shortages, and it has been...
I'm just checking that.
Well, what I want to go on to say is that there's a question of perception here, and I am going to sound like Mr. Angry again, and I'm really sorry, because you are doing a fantastic job in unbelievably difficult circumstances. However, and I'm referring to the aged population on the East Coast, we've got all sorts of problems that are blocking accident, emergency and urgent treatment centre utilisation, often ambulance availability, which is a really fundamental issue in my patch particularly, where the problem occurs when the driver is the one who is unwell. So it's not one elderly person in a household, or it might be, but it's often two elderly people in a household where one is the one who's still driving. Yes, they take their driving test at 75, but they keep driving, and then they're suddenly unwell. They've got a leg ulcer. They don't know what to do, so they call an ambulance, and there isn't an ambulance available. So we're seeing massive waits. The ambulances don't know where to go, and I've just noticed, I've been Googling, I'm sorry for doing that, but Princess Diana Hospital is busy at the moment, it's been closed, so don't go there. But that's the nearest A&E for Mablethorpe, this centre of vulnerability and aged population. It's saying you can go to Boston. It doesn't refer to Louth, and it doesn't refer to Skegness. We have got a massive fundamental problem on the East Coast, and I know we can finesse the discussion about accident and emergency and urgent treatment centres at Grantham, but to be honest, I wouldn't mind living in Grantham in terms of the driving distances, because I know it's not right, but it's a heck of a lot better than we've got on the East Coast. So can I say that we are focusing on an issue in Grantham, whereas actually there is a major issue, despite the fact you're working your absolute socks off in difficult circumstances all along that East Coast. And when Skegness closes, and I just wanted to back up our chair, that was the information I was given, that Skegness was unavailable. There were no doctors available for many days on the road. Now, I haven't got their rotas and their call lists and I can't check, but that's what was coming back to me. So people are unsure of how to access treatment. Thank you.
Thank you. And just to build on what Councillor Matthews has said, you know, obviously we are concentrating on Grantham with this debate. My major concern is, look what we have when we have a UTC, and that's closed. So, okay, I've got a few questions, if I may. So, on pages 74 and 81 of the report pack, there are tables with workforce details for the proposed urgent treatment centre. Can you elaborate on the medical cover arrangements overnight, please? Looks like we've lost everyone. We'll just hold on for a minute and see if we can get someone from somewhere back. We'll give it a couple of minutes. If not, we'll have to probably just move on to the next item. I think the simplest solution is probably, because it's not looking like we're getting anyone keying back in, and it has done.
Hello, can you hear me?
There we go. We've got someone back. Yeah, we can hear you again now, Yvonne. It's not been the
Sorry,
best day for technology,
sorry about
has
that.
it?
I think I just dropped out. So, what? Can you just repeat the question?
Yeah,
for me,
of course
please?
I can. Thank you. Yes, it was on pages 74 and 81 of the report pack. There are tables with workforce details for the proposed urgent treatment centre.
Yeah.
Can you elaborate on the medical cover arrangements overnight?
Okay, so the intention would be to have a doctor on site overnight, who would be supported by two ACPs. So these are advanced urgent care practitioners, supported by healthcare support workers. So that would be essentially the staffing model overnight. We know that historically, the actual attendance of patients during the nighttime period at Grantham is quite low. So when there aren't any patients to be seen, we would utilise particularly the doctor to assist with the clinical assessment service. So patients who are contacting 111 during the night, who get put through to clinical assessment service, they would be able to access that doctor who's on site at Grantham when they're not seeing patients.
Okay, thank you. My second question is, paragraph 10.6.19 of the pre-consultation business case refers to moderate capital investment which would be required for expanding into adjoining departments. Can you indicate how much capital funding would be required for this?
No, sorry, I have to say I haven't been involved in that discussion. I don't think it's a significant amount. Dave, you've got your hand up, so maybe you've got more information than me.
Yeah, sorry, I dropped out as well. It doesn't actually require capital funding for the proposal. However, we did do a business case probably 2 or 3 years ago as to what we could do with, and it was about 1.5 million.
Okay, thank you. And my final question is, how does the extension of Pilgrim A&E affect the overall staffing needs for urgent and emergency care in Lincolnshire?
Sorry, could you just repeat the first bit? How does the
extension of Pilgrim
Right.
A&E affect the overall staffing needs for urgent and emergency care in Lincolnshire?
I suppose the main purpose of the expansion at Boston is to actually provide more accommodation, and at the moment, that one of the problems at Boston is there is often nowhere to see people. So delay in being seen, treated and discharged isn't necessarily related to lack of staff, it's related to lack of accommodation. And it's also that the current layout of the department in the Boston Hospital doesn't lend itself to, to clearly being able to separate those patients who are in need of immediate resuscitation, those patients who we call majors, who need complex diagnostics and specialist input, and then the patients who have more minor problems and are currently being seen in the UTC. So a big part of the expansion is about making the space to manage people more effectively, rather than necessarily needing significantly more staff. And I think because the working arrangement of the proposed building on the Pilgrim site will allow more effective use of the staff that are already there, it shouldn't have an impact on sites in other parts of the county.
Okay, thank you. It's good to know. In which case, I'd just like to thank our two presenters. It's been a bit challenging this morning, I think, with the technology, but thank you anyway for trying. So thank you to Dr. Baker and to Yvonne for their presentation, and also to Charlie. I'm now going to move to the proposals. I'd like to propose that we note the details presented on the Lincolnshire Acute Services Review of Urgent and Emergency Care, to record the committee's initial findings on the proposal for consideration by the committee's working group, and to highlight any areas which the committee's working group might wish to explore in further details. And I think we've covered more than plenty of areas there that we can take forwards. So I'm happy to propose that. Do I have a seconder? Councillor Linda Wootton, thank you. And all those in favour, please show. Thank you, that's supported unanimously. Thank you. Once again, thank you to our presenters. We'll now move straight on to agenda item 7, dental services. This can be found at pages 93 to 107 of the report pack. And I'd like to welcome our presenters, hopefully via Teams for this one. And that's Carol Pitcher, Senior Commissioning Manager for NHS England and NHS Improvement for the Midlands. Alan Reid, Consultant in Healthcare, Public Health and Oral Health. Rose Lynch, Commissioning Manager for Primary Dental Care Services. I can hand over to you for about 5-10 minutes presentation, and then we'll take questions. Thank you.
Thank you. We would like to thank the committee for inviting us to the meeting today to provide an update on NHS dental services in Lincolnshire. I'm Carol Pitcher, one of the senior commissioning managers in the East Midlands team, and I have oversight for pharmacy, optometry and dental services for the Lincolnshire area. And I'd just like to introduce quickly my colleagues, Rose and Alan, if they would like to come onto the cameras.
Thank you, Carol. My name is Rose Lynch. I'm the Commissioning Manager for Pharmacare Dental in the Midlands in the East region.
Afternoon all, and I'm Alan Reid, a consultant covering dental public health in the East Midlands.
Thank you. Hopefully members have had an opportunity to review the agenda item. So I don't know whether you would like us just to do a quick overview of the content in the paper, and then happy to answer any questions at the end.
Yeah, that'd be very useful. Just a quick go over.
Yeah.
As I say, we'll take it as read.
Okay.
Thank you.
Thank you. So starting at the beginning of the report, the first page provides some background on access to NHS dental services. So that NHS dental services are commissioned, and for a provider to be able to see and treat NHS patients, they have to hold a contract with the commissioner, which at the moment is NHS England and NHS Improvement. And those current contractual arrangements started back in 2006. Unlike GP services, there is no patient registration with NHS dental services. People often associate themselves with a dental practice and would be recognised as a regular patient of the practice. However, the dental practice only has a duty to complete a course of treatment or provide a free repair or replacement if necessary, if they have the capacity to do so. In terms of dental practices accepting new NHS patients, again, this would only be if they have the capacity to see and treat new NHS patients for a course of treatment. This does give the patient, a choice of where they attend a local dental practice. So there is patients are able to travel to a dental practice of their choice if they choose to do so. Dental practices in Lincolnshire provide the range of the normal routine dental services, and we do have some specialist services available too. We do have some extended hours coverage within Lincolnshire. So we have 10 practices that provide extended access, and 5 of those actually provide 8 services, 8 a.m. to 8 p.m. On a daily basis, and that includes weekends and bank holidays. So, good coverage in terms of out of hours urgent provision for dental services. And obviously, as I said earlier, individuals are free to approach dental practices to seek dental care. There is information on dental practices on the NHS website, and the link is provided within the report of how to find a dentist. In terms of the following pages 94 and 95, they provide the timeline of the national pandemic response and impact on dentistry. So as members I'm sure will be aware of, the dental sector has faced particular challenges during the pandemic due to the types of treatment undertaken and the use of aerosol generating procedures known as AGPs, and also the stringent infection control procedures that have been in place as well to ensure safety of both patients and staff. This has also, the capacity has also been impacted in practices because of the social distancing requirements also in waiting rooms, and obviously because of the AGP nature of some of those procedures, the downtime that's required between treatments obviously has an impact on the throughput of patients too. The timeline sets out from the start of the pandemic to where we are currently, and as services have been restored, there has been minimum thresholds set within the contractual arrangements for activity delivery, bearing in mind the infection control procedures that need to remain in place at present. Practices still are required to open their normal surgery hours and have reasonable staffing levels for NHS services, and obviously in doing that to maximise their capacity to see and treat patients as much as possible. There are some contractual mechanisms in place for those that fall below the thresholds identified in the paper. For the current quarter, we're now operating in for the October to December 21 period. That at the moment is a threshold of 65% for general dental services and 85% for the orthodontic specialist services. And for practices to maintain that they do receive 100% of their contract value. So to meet that income protection, there are some other commitments within this that they need to prioritise urgent care. And at the moment, there is a focus on seeing and treating vulnerable patients, and that obviously all NHS funding is utilised to provide NHS treatment. The pages 96 to 97 give some information regarding the establishment of the urgent dental centres that we had to do, obviously, initially at the very start of the pandemic. So for Lincolnshire, we mobilised them in Lincoln, Boston, Louth, Spalding and Sleaford. The majority of those sites were already our established 8 a.m. to 8 p.m. practices. So they did give the optimum combination of we thought, geographical coverage, opening hours and workforce as well to support those 5 practices. And they do continue to support other local practices in the area in providing care for those that are in an urgent need who may not have that usual dentist to approach or might be new to NHS care. There is a pathway for accessing dental services, whether that be urgent or routine, and generally on the whole that is utilising the communication information that's available that will signpost a patient how to find an NHS practice, or contacting obviously NHS 111 if that's outside of normal surgery opening hours. Going on to page 98, this covers the Lincolnshire dental service performance. Obviously, as highlighted a moment ago, activity was completely suspended from the 24th of March until really the 8th of June 2020, with really only urgent activity being undertaken through those urgent dental centres that were established. We've then been working through a phased recovery since June 2020, going into 2021, and obviously activity delivery levels are continuing to improve. If I then go on to page 99, there is a chart, figure 1, which shows the range of activity delivery for the first 2 quarters of this year. Obviously, as mentioned earlier, I mean, members will see there is a range in there of those contracts delivering at the lower end of the range, and obviously some where delivery is beyond the minimum thresholds or achieving pre-COVID levels of activity. We do have some contractual mechanisms that we will be working through at the moment. We do have what we call a mid-year review process, so that will be looking at these first 2 quarters, and obviously there are processes in place to financially reclaim money from those providers that are underperforming, so we can reinvest those to support that dental service recovery. But we will also obviously engage with those providers too in a supportive way, so we can look at action plans or whether there's any other areas of support that we could work with them and work with providers to enable that capacity to be delivered and increase further, so that, you know, obviously increases access for patients and availability of services. On page 100, the graph in figure 2 does demonstrate the impact that the pandemic has on what we call the unique patient count, which is the measure we use for access to NHS dentistry services. So the graph does show there was a significant decrease in access for both adults and children, and that can be seen by the steep decline for both Lincolnshire and the Midlands in the data depicted in the graph. From a point of view, actually, in terms of equating that to a number of patients, this equates to approximately just over 74,000 patients that would have ordinarily had a visit and been seen in those dental practices in that previous probably 18-month period. So obviously for dentistry at the moment to be fully restored, there is still a significant backlog that we are working towards being addressed. If I just go on to the next bit around really some of the initiatives that we're looking at within the Midlands region to support that recovery and restoration of services. There are a number of schemes that are within the paper that appear on the following pages, which include the weekend access scheme, the ventilation scheme, again, because that would help improve throughput of patients and reduce the downtime between procedures, and the dedicated 111 slots. We have recently, within the last few weeks as well now, been exploring other initiatives to further increase dental access to patients across the whole region, which includes Lincolnshire. So over the next few weeks, we will be going out with some further communications to all our providers, including Lincolnshire. And these include, at the moment, we will be doing a phase 2 of the weekend access scheme again. So we will offer existing participants an opportunity to provide additional weekend sessions again if they have the capacity, and also invite new applicants to this scheme. We are now looking at where those practices are looking that we believe they're working towards delivering 100% of their usual activity. Again, if they are in a position to be able to provide more capacity, and that would normally be classed as over delivery, that we would look at providing some funding to support that over delivery up to 104%. We are looking also at some of our specialist services. So we are looking at the long waiters that we have within the orthodontic services, and how we again can commission additional activity with those providers who seem to be, looking like they're reaching their pre-COVID activity levels. We have a child access scheme as well that we are looking to set up in every local authority area that will work and support our community dental services providers, so we can improve that access for children and the prevention and treatment that's needed for that group as well. And then finally, we've also in the latest investment schemes had additional investment approved for the development of oral health promotion services as well. Again, this work is very important in terms of strengthening that preventative agenda and tackling those health inequalities. And Alan, my colleague, will obviously cover the oral health element in more detail shortly. And just to sort of finish off, we have all of those initiatives that obviously are in-year initiatives that we're working on to bring forward that restoration and recovery of those services. But we do know also we do still have some additional general dental services in Lincolnshire that we were preparing prior to the pandemic for commissioning and procurement, which unfortunately went on hold and were paused whilst we managed the situation in dental services. So we will be looking to move those commissioning intentions and procurement plans forward and look to commence, and they are mainly with the recommissioning of services for Mablethorpe, Spalding, and we had some new capacity for the Skegness and Spilsby area as well. So that will be hopefully moving forward in the new year. So that will bring in additional capacity, not within this financial year, but hopefully towards the end of the next financial year. And then finally, before I pass to Alan, just to note on page 102 that there was 2 recent appointments within our teams as well. So we now have Kenny Hume, who will be our Lincolnshire Local Dental Network Chair. Committee members may be aware of Kenny Hume because he is the chair as well of the Lincolnshire Local Dental Committee. And obviously Kenny will be supporting that network programme, as Jason Wong did previously, who had attended the Health Scrutiny Committee with myself. And then also we have Adam Morby, who's our Regional Chief Dental Officer. So I'll just pass over to my colleague Alan now, so he can just run through and give some headlines from the oral health update too. Thank you.
Thanks, Carol. Yeah, just a quick overview. I've included a section on oral health in Lincolnshire, covering child oral health. I've given some of the data for the survey of the 5-year-old children's, the latest data for that, showing that the key areas of concern for Lincolnshire are Boston, where close to 40% of 5-year-old children have decay experience, and that's the highest in the East Midlands. Also areas of North South Holland and East Lindsey, and also parts of Lincoln City itself, which has higher levels of 5-year-old decay. just to point out, the 5-year-old decay is a really good proxy indicator of oral health status across the life course. There's a really strong correlation with that. So that's an important measure that's undertaken through survey every 2 years. I've also put a map in figure 4 mapping out the prevalence of dental decay in 5-year-old children, and you can see that there's a really marked east-west divide in dental caries. So the west of the county, which enjoys the benefits of fluoridated water, has far lower decay rates in 5-year-old children than it does on the east side, which doesn't enjoy have that water fluoridation. And you can see really the impact and the protective effect of water fluoridation on children's teeth. So, and of course that correlates with the fact that actually conversely the east of the county and the coastal areas has the poor service provision with workforce issues and access to dental care. So really that inequality and disparity across the middle of the country, the county, that's really stark. Just going on to adult oral health. A adult oral health survey was done in 2016, looking at vulnerable older adults, and we found that actually the higher need of domiciliary visits for older adults was identified in Lincolnshire. We had higher levels of treatment needs in certain population groups, so males in particular, and obviously from materially deprived backgrounds, and also people with learning disability as well in Lincolnshire. Just to go on, just to explain what we're doing locally, we've responded to that through the Oral Health Advisory Group, which is a multi-stakeholder group that's hosted by Lincolnshire County Council, bringing together people across the health and care system, including NHS commissioners, to devise strategy and implementation of that to improve oral health. And one example of that for older people's oral health is the establishment of a care homes programme to upskill care home staff around oral health improvement within their care homes, and that's really evaluated well. So I'm just conscious of time, I don't want to take up too much, but there's identified needs which has been addressed through a really proactive oral health advisory group in the council, and I'll leave it at that and happy to take any questions.
Thank you, that's useful. Councillor Parkin, I know that you've got to be going in the next 5 minutes or so, so if you want to ask the question before you go.
Thank you for indulging me like that, Chair. I'm really interested and a little bit bothered here by the commissioning model here, because you're obviously commissioning as an East Midlands entity here. How does your commissioning model for Lincolnshire differ from, the urban centres of population that we have in the East Midlands as a whole? Because obviously our needs here are going to be very, very different to your Coventry's, your Nottingham's, your Leicester's, which I'm assuming you're also covering.
Yeah, we do look at each of our areas within East Midlands on a separate basis in terms of needs. So we do obviously take into account the rurality of Lincolnshire, say, in comparison to the city practices we may have in say somewhere like Nottingham. So it isn't done at a high level in terms of the commissioning. It is down at those individual what we use the term system areas. So for us that would be Lincolnshire, and looking at the geography of Lincolnshire, the services we've currently got commissioned, where those gaps are, gaps in specialist services. So although we may take things forward on an East Midlands footprint, below that we do look at the 5 areas within that in the East Midlands on in a detailed level.
Yeah, just come in there. That's supported by place-based commissioning through localised needs assessments that we do for each area.
Okay, thank you. I've got a list of another 6 speakers, so I will ask just to try and keep it as tight as possible, please. Councillor Whittington first, please.
Yeah, sorry. Yeah, sorry. Thank you, Mr. Chairman, and thank you, Carol, for a very and Alan for some very interesting presentation. My first sort of point is really around the contracts, because you sort of, I think, Carol, came up with a sort of a real difficult situation you're in, that you seem to have an increase in demand all the time, but you have capacity and supply issues, so there's some real horns of a dilemma there with that. So my questions are really initially around capacity. Obviously, my understanding is that of dentists, some are entirely private patient, some do.
Yes,
yeah, some do. Are there any that just do purely NHS patients?
We do have some practices that probably maybe 90% plus NHS, but all NHS practices are able to offer a patient, even an NHS patient, the option of a private treatment. That, you know, they do have to obviously offer the patient the NHS offer, but they can say, but if you wanted to, you know, it may be a fill-in would not be a white fill-in, say, on the NHS as part of that course of treatment, but the patient wanted the white fill-in, then they may offer them that as a choice as private treatment. But as long as they've offered the NHS course of treatment and what that would be, it's down to patient choice then whether they proceed with the NHS treatment or private option. So most practices do have a mix, and that percentage of mix does vary practice to practice.
Yeah, I think because that's one of my questions I was going to ask. But also, of the entirety of in Lincolnshire of the dental practices, what proportion will offer some level of NHS care? Is it 20%, 40, 60, 80? Any ideas on that?
Do you mean in terms of how much patients may be accessing private treatment or NHS?
Just an indication of those practices that are only doing private work, in effect.
One, not really, because we don't have the information on the private dental practices. Right. So we do know of the NHS practices that obviously, you know, majority will have some private option they offer. But again, we don't have the information on private practice and their earnings and the level of treatment that they deliver.
Fine, thanks. In terms of the contract, is the contract you have, is it a block contract, so you're just paying a fixed amount? Is it a cost per case contract? Is it a mixed contract?
Most of the contracts we have, so this is a national contract, it's not a locally determined contract. They are nationally designed and implemented contracts, but they are on the whole on a block basis. So they have, for a year, they'll have an annual activity level and an annual financial value associated with that then is monitored through the year. We do have a few services where they are more on a cost per case basis, but in percentage terms, the majority of certainly our general dental services will all be on those annual based contract arrangements.
Thanks very much, Carol. I've got one final question, which was on, in terms of children's oral health, and you listed some of the sort of steps you're taking. One thing I did notice wasn't there was any link to children's poor oral health and sugar. I'm thinking about not just sugar that's possibly obvious in soft drinks like, you know, but the kind of hidden sugar that is in a lot of processed foods, and maybe there needs to be a link there, because I know there's a campaign against sugar. I'm just wondering if there's a link there between what you're doing and the public health work that the County Council does. Thanks.
Yes, I'll let Alan, both myself and Alan are linked into the Oral Health Advisory Group with the local authority too, but this is probably more Alan's area of expertise.
Thanks, Carol. Yeah, absolutely. Sugar is the prime cause of tooth decay in children and adults as well. Yeah, so all interventions are targeted to both upstream and downstream to mitigate against that and to improve diets, and also protect the protective effect of fluoride through toothpaste, fluoride varnishes, and also through water fluoridation as the ways of accessing and getting fluoride onto teeth. So absolutely, that's a key fundamental aspect of dental public health.
Thank you. I've got Councillor White next.
Yes, thank you. I think it's very concerning that children are now dependent on their parents referring them to dentists. There must be a large number of children who don't see a dentist, and other methods that you've mentioned seem rather haphazard. I mean, for example, health visitors, in my experience, they're not operating as they were before. They're not going into the families to a large extent. I'd also like to make a comment. I live in the Lincoln area, and there was a problem about finding dentists before COVID. And I know from experience of one of my residents who had two teeth removed, the roots were left in, tried to find another dentist. He had to have the roots removed at Boston Hospital, but couldn't find another dentist to register in alternative to the one who'd left the two roots in. Thank you.
Yeah, I mean, I think in terms of the children access, I think as Alan's indicated from the oral health information, there are particular pockets that we've got within Lincolnshire where there does need, in terms of what we're looking at for the access for children and the oral health prevention, fluoride varnish, etc., that Alan covered, that we, you know, that's one of the reasons why we're looking at the scheme around child access, because we do want to, within the local authority areas, try to find other ways and how we can get those children, wherever they may be coming to us from, get them into those services as early as possible. So we do take that on board, and unfortunately, as you've said, the pandemic hasn't really helped the access position for patients due to the suspension and then the recovery of services over this period of time. But obviously, we are trying to continue as much as possible to improve that access where we can, and to try and, you know, work with the practices and the profession to see if there are other initiatives that we can you know, move forward more and start addressing that backlog, and also increase the access that we had pre-COVID as well.
Thank you.
Okay, thank you. Councillor Woodliff.
Thank you very much indeed, Chairman. Well, this is a diabolical report. The situation in Boston is terrible, absolutely terrible. Now, the question I ask is I presume there's no school dental service anymore. I also want to know what the number of dentists are in Boston or available, and the proportion per 100,000 people. But I mean, there are no answers to this, are there really? Unless you have the dentist, you can't provide the service. Huge numbers of children appear to have serious dental decay, and I've read through the report several times. I mean, it just makes horrendous reading. And it's almost a breakdown of the health service, really, in regards to dental surgery, dental practice. Clearly, it's not a profitable place to be. There are private dental provision. There is private dental provision in Boston, fortunately, and I take advantage of it. I have to, because originally the dentist was actually in the NHS, and he said, "That's it. We're moving away from the NHS. We're not going to do it anymore. I'm going to go private." So, what option do you have? You have to go private. So that's the way it is. I think it's an appalling report, and there doesn't seem to be any plan here to be able to resolve this situation with these large numbers of children who are growing up with serious dental decay, and there's no plan here to deal with it. A lot of talk about people getting together to have little chats and so on, but there's nothing here. I think it's a scandalous report, and something needs to be done about it. We do need more NHS dentists in Boston area, Lincolnshire. We do need more doctors in this area. I did read in the press the other day that the government's going to try and push people this way. Stop people going to nice leafy areas in Surrey and send them here. I suspect it won't work, because I suspect the doctors will simply say, "I would prefer a nice leafy place in, you know, Paris or somewhere." or somewhere. So I don't know what question to ask. I've asked three, what's the number of NHS dentists available in Boston, and what's the proportion of them per 100,000 people? And what about whether it's a dental service or whether dentists are going into the schools at a young age, in the primary schools, and checking dental health? But I suspect none of that's happening. Complete breakdown of the service. And I think it's very bad because we know that dental decay leads to so many other serious problems in life. You know, so I have no answers, and I'm sure you have no answers.
I think if I can just come in there just to give some assurance or some level of it. Carol, we have the community dental service provision, and there is coverage in Boston. It is Boston, and you'll see also Leicester, and just as a comparator, that's got traditionally high levels of decay as well. And there's lots of factors for that. It's deprivation. People whose background is whose first language isn't English or come from Eastern European backgrounds or other communities that have social disadvantage. So the community dental service is targeted in there, and it does make a difference. But you're right. I mean, ultimately, there is a need for improved access to services in these coastal areas, and including Boston and that as well.
I'm afraid to say, Chairman, it's a statement of failure. This is just a statement of failure, and there doesn't seem to be anything to be done here to improve this situation. Thank you, Chairman.
Okay, thank you, Councillor Woodliff. Something that's not been mentioned in the report and feeding into an element of what's been said by Councillor Woodliff is we've had our pre-scrutiny meetings, and during that point, we were having a conversation with the clinical commissioning group, who informed us that they will be taking control of commissioning for dental from April. But it's not mentioned at all in here. Would you care to expand on that somewhat, please?
Yeah, at the moment, the pharmacy, optom and dental services that currently are commissioned and sit within NHS England and NHS Improvement, there is a transitional plan for that to be in the future devolved and delegated to the integrated care systems. So at present, as far as I'm aware today as I'm speaking, for Lincolnshire, that will be a joint arrangement from the 1st of April 22, with that being fully delegated from April 23. So at present, I think the conversations are taking place now between the individual ICS systems and colleagues within NHS England and NHS Improvement, and drawing up that critical path of how these services will transition over, and we start working together jointly for those local areas. So for Lincolnshire, that will be obviously working with colleagues at the moment within Lincolnshire CCG and the Lincolnshire ICS in the future. So that will start to transition over the coming months. But in terms of the actual dental commissioning, the current contractual arrangements obviously will still be in place. But if we do any new and that future commissioning for those services, say for Mablethorpe and Spalding, etc., we will be working more closely with Lincolnshire to to discuss what those services are that we're looking at to commission and work together on those going forward in the next few months. So I'm sorry, apologies that wasn't. I think it's sort of, as far as I know, in terms of it's going through Parliament, isn't it? In terms of making those decisions that these services will be delegated and become part of their ICS in the future. So locally within the region, they're working now with all those systems of how we take that forward and start working together.
Thank you. It sounds like a much more sensible approach. Councillor Cleaver.
Thank you, Mr. Chairman. Can I say that sections 1 to 7 of this report, from a scrutiny point of view, aren't telling me what I'd like to know about, frankly. I look on the NHS website and it says, quote, "The NHS will provide any clinically necessary treatment needed to keep your mouth, teeth and gums healthy and free of pain." Now, I'm approaching this from the point of view that the second largest number of complaints I get from my residents is about not being able to get NHS treatment at a place that's within any reasonable driving distance. And I'm not seeing in this report why that is happening, and I'm not seeing any proposed solutions to it. It appears in sections 1 to 7 of the report that what we're seeing is a very detailed description of how a service has dealt with COVID, but no addressing of problems that existed before the pandemic and are going to continue existing afterwards. So can you tell me, for example, how many people in Lincolnshire are entitled to free NHS dental care who are not receiving it? That seems to me a key thing that we as a Scrutiny Committee would like to know. Similarly, I mean, I can't go back to my residents who say we can't register an NHS dentists and simply tell them, well, the concept doesn't exist, you can't register with a dentist. That's really not what they're going to want to hear, frankly. In terms of the way the commissioning model works, in terms of the volume of activity and the budgets, are they going up, are they going down? We don't know from this report what's happening. We don't know how the budget is divided up between other parts of the East Midlands compared to Lincolnshire. We don't know how much NHS provision there is in different parts of Lincolnshire. So in terms of being informative, I'm afraid that sections 1 to 7, in my view, very much fall short of what we as a Scrutiny Committee would expect from a report. By contrast, section 8 about oral health is incredibly informative. Thank you very much for that. It is highlighting problems. It is showing us things that need to be drawn to our attention, and clearly very serious. I mean, there's a serious disparity in health there between those different areas, which I would never have dreamt actually was going on. So that's very helpful to have that brought to our attention. And I hope it's something that we can, in future meetings, look for some solutions to, because we're clearly not going to be able to do that today. Thank you.
I mean, we could take some of those points back. I think probably this report was probably more focused on the pandemic and the recovery from the pandemic. But we do accept that there are obviously issues that existed pre the pandemic, and we do now need to move forward once we have that recovery and restoration to address some of those issues. I mean, we can look at some of the information to give a more detailed picture for Lincolnshire, if that would be helpful for the committee for the future paper. And obviously there is work ongoing that Alan is involved in as well, around looking at that need across various areas within the East Midlands as well. And Lincolnshire will be one of those areas that will be being reviewed in terms of general services need and also specialist services. So that there are some pieces of work going on in the background as well. However, you know, in terms of where we may have been with those 2 years ago, we've obviously had to manage and focus on that provision of urgent dental care need initially, certainly during the first 12 months of the pandemic. And then this year we're trying to obviously restore those services back up to those previous levels. So it doesn't necessarily paint a good picture, and we do take that on board. But we are trying to work as hard as we can now with providers as well, and with whatever commissioning tools and funding we have available to try and bring that back to where it was as soon as possible.
Thank you for that.
Okay, thank you, Councillor Cleaver. I mean, quite clearly, with many of the reports, they have been all COVID-based. It's normally sort of a little bit more in-depth, but I would live in hope also when it does start making the move across, as I said earlier, when you've got a more local aspect looking at it, that of course there is that method of change will come along with it. So, thank you. Okay, Councillor Matthews, please.
Chair, first off, let me apologise. I'm going to sound like a broken record today. I can tell, Carol, there are 12,633 people in Mablethorpe who are entitled to NHS dental service and do not get it because there is no dentist in Mablethorpe or Sutton-on-Sea, not a high street dentist, not a private dentist. The nearest one is in Alford, which is 9 miles away, and they are not taking any patients at all. And that situation has been ongoing for at least the last 4 years. So I have 2 requests. My first one is a simple one. Please, can you move forward the contracts for Spilsby, for Mablethorpe and for Skegness as a matter of urgency? This is nothing to do with COVID affecting and reducing services. This is there not being a service available. And it's great that you've commissioned it. I'm so pleased. Please move it forward. To hear it's not going to be done by the end of the financial year is not good. My son's a dentist, interestingly, so although I count myself among those 12,633 people living in Mablethorpe and Sutton-on-Sea, I go down and see him twice a year, and he says, "Oh, come on, Dad, get in the chair, everything's all right." If I have an emergency, I ask him to send me some a prescription by post, and he diagnoses me over the phone, and we sort it out. I've got people in Mablethorpe who are self-dentisting. It's not very clever. And they're coming to me and saying they cannot get an appointment at their GP. Now, that's a separate issue altogether. But if they get to the GP, they then can't get to a dentist, so it's not good. Alan, my second request is for you, and I'm looking at the graduated page about children's oral health, because it looks as though everybody who lives in Grantham's all right. And I said earlier, I wish I'd moved to Grantham, and I think probably I would, because I'd have better teeth. But what you're showing is a block coverage of an average there. And I'd really like you to dig deeper into this and look at the graduation of the colours as they move towards the East Coast, because I'm absolutely sure that the average, which is above both the National and the East Midlands, is even higher if you were to segment out Mablethorpe, Sutton-on-Sea, Chapel St Leonard's, and move down towards Skegness. So I'm asking you to do that. Please give us some finer granulation, because I think you'll find that our oral health is not very good on the East Coast. My son trained in Glasgow, and you sound as though you've got a bit of an accent there. His first practice was in Sauchiehall Street.
Oh, yeah.
And he did a great deal. It was a shock to him to work in a dentist in Sauchiehall Street, because he found that people were coming in and asking for a full extraction. I don't know the technical term, but basically it was a 21st birthday present. Mums and dads paid for their children's teeth to be removed, because that was a better option going through life than having the mouths that they had got as a result of practice. And I fear this is happening in East Lindsey, and I fear it's happening on the East Coast. So please move that contract forward.
Yeah, I mean, in terms of Mablethorpe, obviously, I was involved in establishing the urgent dental care sessions at Mablethorpe, because we knew we had a gap and we needed to be able to provide, as a minimum, some urgent dental care there. And that was initially only for a period of 12 months, because we were going to re-procure the services within the Morisco centre there. However, unfortunately, as the pandemic came along, the procurement plans that had been drawn up at that time obviously had to be paused. And I know Rose may want to add as well. So some further work has been done, because obviously as we're coming out of the pandemic now and the recovery of services, we needed to engage with the market and providers just to see, is now the right time to do those procurements, and would we get the interest in those areas to come and establish those services. So we obviously we have maintained the urgent dental services there, so I hope that's helpful. But Rose may be able to add a little bit more in a minute. That there are plans now in place to get that restarted again and to go out to the market, because we believe now we will receive some interest for these services in that area.
Thanks, Carol. Yes, that's correct. In terms of ensuring that there is an appetite in the market, because it will be quite a, shall I say, a pointless exercise if we went out to procurement for service in the Spalding, Mablethorpe area for no providers to come forward. Hence why, obviously, we've been going out for the test the market to understand is this now the right time. We recognise the constraints in terms of the workforce, the capacity, people are overworked, they're exhausted. So we're trying to do what we can in terms of increasing access in the interim, i.e. with Carol saying about the urgent provision in Mablethorpe, the access schemes we have, but in the background, before the actual formal procurement commences in the new year, a lot of work is happening in the background in terms of linking in with the market to understand it is now a good time, the service specification, and it's about getting the right model out there to ensure that it is a success when it does formally go out.
Thank you. Councillor Harrison.
Thank you, Chairman. Councillor Matthews has obviously covered some of the things I wanted to raise, but this big red patch is absolutely shocking. I'm wondering, how did it get to this state 5 years previous to 2019? Has East Lindsey and the coastal area been totally neglected by all research to be aware of this and work on it? So, yes, you've indicated it's going to be targeted in the future, but it will take a long time to catch up.
So
it's very
can I
worrying.
just...
And if I also might add, are any agencies working together to try and get fluoridation in this area of Lincolnshire?
So I'll come in there. In terms of trend over time, actually, as a whole, it's actually improved. That's an improving picture. So I wouldn't want you to think that's just a snapshot of 2019 and that's what it is. The eastern side has always had poorer oral health, and actually it hasn't really increased over time of the last 4 dental surveys, which take place over every 2 years, so at least over the last decade. So there is actually some improvement in some areas, but it's still it's largely driven not just by access to service, but it's mainly driven by deprivation, which you'll find in coastal areas more prevalent than elsewhere. In terms of fluoridation, we obviously advocate for water fluoridation. You can see the stark difference between the west side of the county where the water is fluoridated, and that would have a massive effect, improvement effect and protective effect for children's and all adults' teeth. It doesn't just have an effect on children, it's beneficial across the life course for dental health. In the recent white paper that's going through Parliament for the new health and care bill has actually got plans to shift the delegation responsibility from local authorities for water fluoridation back to national, and I think just recognises the fact that it's actually the current legislation to get local to allow local authorities to put in a water fluoridation scheme or adjust it or expand it or have a new one is actually very complex, because local authority water supplies don't sit nicely within a local authority area. There's got to be a consultation, of course, with wider the public and also with other neighbouring local authorities that might be affected by that. So the plan, we welcome that move from water fluoridation schemes regulation being moved from local authority up to national, and we hope that that's going to make a big difference to that going forward.
Thank you.
Thank you, Councillor Harrison. Okay, I have a few questions still to ask. So one of them is, do you foresee the availability of NHS dentists in Lincolnshire improving in the coming years?
In terms of the current situation, yes, that should improve in terms of where we are now with the recovery of services and the additional initiatives that we're doing. You know, the procurements that will commence next year, again, that will increase access, because that will give access to those people in Mablethorpe and Spalding and some additional capacity in Skegness. But I think there's still ongoing work that we need to do, and we will be working with the new ICS with this in terms of, like some of the councillors have mentioned, looking at the detail around the Lincolnshire position and those coastal areas as well, and where we still feel that level of commissioning is still not not sufficient necessarily to address those access questions. So I think there is still some further work for us to look at and work together within either with the local authority via the HOAG group we have, but also with the Lincolnshire system moving forwards.
Okay, thank you. And at our last presentation, we were advised that overseas recruitment would be used for the first time to help with recruitment. Has this yielded any positive outcomes, and what is the current picture with the retention?
No, unfortunately not. The scheme that Jason Wong was developing in terms of the overseas dentist recruitment, again, that was put on hold. So in terms of taking that forward and recruiting, because they were EU dentists into the workforce, that didn't take place. We are working with Health Education England now on the workforce, because again, as some of the councillors have mentioned as well, there are workforce issues within Lincolnshire. So, you know, even if we commission more services, we still need to have the workforce locally to deliver this. So we are working now with Health Education England on other initiatives that we could look at to attract the workforce to Lincolnshire. Again, we did recently come up with a scheme that we could work with a number of practices in Lincolnshire to take on a recently qualified dentist into those practices and support them. But again, unfortunately, there were no applicants for Lincolnshire from those trainees. So we have taken that back, and we need to look at that and see what we need to do in terms of changing that offer going forwards. What else can we do in terms of positioning Lincolnshire as an area to come to work in, etc. So workforce again is another work stream that is the team alongside public health colleagues and Health Education England colleagues, and also as well as the dentist workforce, it's looking at whether there is other programmes we can look at around skill mix of current dental workforce, as in the dental therapists and hygienists, and upskilling of dental nurses, to see how we can look at the full workforce in terms of delivering some of the initiatives we're looking at in different ways.
Can I just add to that as well? It's also with the newly appointed LDN chair, Kenny Hume, who will be pivotal in his role with linking in with the providers on the ground and with ourselves as commissioners of NHSCI to drive that those initiatives forward and the strategy and how we can increase access in Lincolnshire.
Okay, thank you. I think it's disappointing that we have these reports sort of every year. I've been on this committee as chairman now for 5 years. And over the 5 years, I struggle to see any form of improvement that's been made. And I think that's incredibly worrying. And, the reports and what we're hearing today, I heard 5 years ago. I have a question now from Councillor Allen.
Thank you, Chairman. I tried to be quiet this committee meeting because I do tend to get depressed and then shout a lot. And I'm very glad that you said what you said to a certain extent, because it does seem from the various comments that have been made, as well as the presentation, that the situation regarding dentistry in Lincolnshire is fairly dire, to be honest. And my experience of NHS dentistry in Lincolnshire was one visit to a new NHS dentist that opened up in Sleaford. And I went for my 6-monthly checkup, and he said, you luckily don't need any teeth out at all. So I said, well, I haven't really come to you to have my teeth out. I've come to you to ensure that I don't have any teeth out. So I said, as far as I was aware, my teeth are all right. I just need my normal descale and polish. To which he said, well, that's not on the NHS. That's private. So I went private because it seems to be a far better system that you've actually got if you go private. And I would point out that my private dentist has kept operating all the way through COVID in a secure and proper way, and I have not missed one of my regular checkups, and my wife has not missed a fairly significant treatment that she required. So that has happened. Can I suggest, and I think it follows on from what you just said, that these reports that we get don't really seem to give us the information that we need to actually carry out our scrutiny role. The information isn't there. The point has already been made that you could almost ignore the first, 7 sections of the report, which are talking about COVID and the recovery from COVID and all the rest of it. And it may well be that's what the report is there to do. But if we are moving on to a new system in a year, or for April next year, to be effective in a year, could I suggest that we ask for a detailed report that gives us the information that we actually need to understand what the situation is regarding dentistry and how we compare in Lincolnshire with the rest of the country as well, because it strikes me that we don't have very many dentists. I don't know whether that's the situation, very many NHS dentists. I don't know whether that's the situation generally or whether we're just poorly served. And I don't know whether it is the situation that there is a disparity across the county as well. Yes, it might be florid, but I have a feeling we've probably got more dentists on the west side of the county than the east side of the county, from what I hear from colleagues that represent the east side and the county and the coastal areas. We need proper information about how many dentists we've got, where those dentists are, where they are supplemented by private dentists, and how many processes and procedures, and how many people within the county have got actually getting access in any way at all. Yes, there's not many that seem to be going through the NHS system, but does that mean that the private system is not picking up what it can do, or is it picking up enough to actually keep us safe? Not from the look of things, and certainly not on the east side and the coastal areas.
Yeah, thank you, Councillor Allen. I mean, I'm more than willing to take that on board. I mean, what I would suggest anyway is we probably on this instance ask for an update in 6 months, because I think this has been a COVID update. We do have to give our NHS colleagues that. This is, what they've been asked to do today. However, there is a lot more information we could do with bottoming out. I would even add to that, you've had personal experiences and so have I. I'm with an NHS dentist that also has a private arm. For 2 years I've had issues. I'm waiting for a root canal surgery a week on Friday. But I couldn't have that done by my dentist. I had to pay £700 to have it done privately. I've barely got the money for that. I'm sort of struggling myself. So those that need a basic root canal, you're not even in a position to be able to afford to do it. So there is a lot more we need to look at. And I think in terms of how much is pushed towards the private arm of these dentists that do NHS cover. So I would like to take that on board as well, I think. So I don't know if our NHS colleagues would like to come back.
Yeah, I know. I was just going to say I'm sorry to hear about your experiences of NHS dental treatment. Certainly with Councillor Allen, if the scale and polish was clinically necessary, that should have provided as part of that NHS course of treatment, and shouldn't have been a private option. But we do take on board feedback that we get from patients if those issues are raised with us with the practices. And I do hear around the report, as you said, I think the report has been drafted in a way by the team as giving that update around the pandemic and coming out of the recovery of that. So certainly we're happy to look at the next update in 6 months, providing some of that more detailed picture for Lincolnshire that councillors are seeking. And I'm happy to work with Simon and colleagues if we need to do that, to make sure that we get that level of detail and data right for the next update. Thank you.
Thank you, and thank you for taking that on board as well. So I'd like to thank our presenters. It's been very useful, I think, going through it, and from the COVID side, knowing what pressures you've been under. I think we've all seen firsthand that every element of the NHS has been under immense pressure, and I think that those dentists that have continued to work hard through the pandemic, we would all say thank you. So I'd like to propose that we note the information presented by NHS England and NHS Improvement on dental services in Lincolnshire, and to seek a further update in 6 months' time, taking on board the comments of the committee. Do I have a seconder for that proposal? Thank you, Councillor Linda Wotton. All those in favour, please show. Thank you, that's supported. Now I'd like to move on to agenda item 8, the Health Scrutiny Committee Work Programme. I'll hand over to Simon just to go through it quickly.
Thank you, Chairman. I'll be really brief. The items listed for the 15th of December are set out on pages 110 and 111 of the agenda. It looks like the nuclear medicine item is not going to be coming forward to the December meeting, but as the chairman mentioned earlier, there has been a briefing for the chairman and the vice chairman on the Humber Acute Services Review, and it looks like we'll be expecting an item or planning an item for the December meeting, providing an outline of some of the implications of that review. Thank you.
Yes, thank you, Simon. Councillor Whittington.
Yeah, thanks, Mr. Chairman. Just looking at some of the items yet to be scheduled. I know one of those items is the future commission arrangements for dental services, which I think was mentioned in the previous item. So I'm guessing that potentially that will need to be scheduled. I'm thinking for sometime in the new year. We've also got the second item down there, the non-emergency patient transport, Thames Ambulance, which you currently have the contract. The new contract starts on the 1st of July 2022, and I'm just thinking, again, we're going to need an update on how that's going pretty soon into the new year, because we're obviously aware of the issues with the current contract with Thames Ambulance, and it'd be interesting to sort of see who the potential providers of that service are, and hopefully the system could be different. And I know that there's Lakeside Healthcare there, which I'm pretty sure is why Councillor Cleaver's got his hand raised. He's smiling at me. So thanks, Mr. Chairman. Thank you.
Thank you, Councillor Whittington. Yeah, absolutely. I think looking at the items there, and of course we've now got the Humber Acute Services Review and everything in between, I do think we may be looking at perhaps longer meetings, perhaps even going into the afternoon with what's there. So I do take that on board. Councillor Cleaver first, please.
Yes, indeed. Do we have any indication from the CCG as to when they will be able to tell us about their lessons learned at all?
Not at the moment, Chairman, but we need to. I will pursue that. Thank you.
Thank you.
Councillor Wotton.
Yes, thank you, Chairman. Do you have any potential dates for our working group reviews at all yet? Thank you.
I think that will come out of today, Simon, won't it, realistically? So we will be setting something, because we will be needing to move on pretty quick, because we do have, obviously, next month the next two items. Yeah. Okay. Councillor Harrison, please. Okay, thank you. Yeah, we will start sending them around, but we wanted to get the right steering, and we felt that the debate in the chamber first was important today, and then obviously it gives us another couple of bites at the cherry, so to speak. So any further comments, please? Anyone else? No? Okay, thank you. Well, that's all noted down, and I'd like to thank everyone for their attendance at today's meeting. I think it was an excellent debate, and thank you all. That brings the meeting to a close.